சார் யூடியூப் ரெடி ஆயிடுச்சா? சார் யூடியூப் ரெடி ஆயிடுச்சா பாருங்க. அந்த லிங்க் எப்படி எடுத்துக்கோங்க. ஒர்க் பண்ணல இல்லை சார் எடுங்க இல்லை சார் அதில் சார் பண்ணுங்க. சரிங்க சார் இதோட மினிமைஸ் பண்ணிக்கலாமா? இந்த வாட்ஸ்அப் போட்டு நான் ஷேர் பண்ணி இந்த சார் பண்ணிடுறேன் வேறு சார் அதுதான் நான் உட்காந்து இது பண்ணிக்கிறேன் கான்டாக்ட் பண்ணிக்கிறேன். இந்த இப்போ அனுப்பிச்சுடுறேன் சரிங்க சார் சரிங்க சார் எடுத்துறேன் சார் இந்த ஒரு வருஷம் அனுப்பிடுறேன். இந்த ஒரு நிமிஷம் சார் சொல்லுங்கள்.
ஹலோ நான் பார்த்தேன் சார் வந்துட்டாங்க. இப்போ ஸ்டூடெண்ட்ஸ் எல்லாம் ஜாயின் பண்ணிட்டு இருக்காங்க. கொஞ்சம் லேட் ஆயிடுச்சு. இப்போ தான் ஜாயின் பண்ணிட்டு இருக்காங்க எல்லாருமே. நியர் அபவுட் ஒரு 200 people வந்தாலும் ஸ்டார்ட் பண்ணிடலாம். அரௌண்ட் ஒரு 10-15 போல. ஓகே
சார் நான் செய்ய சார் ஓகே நான் இப்போ பார்க்குறேன். இருங்க நான் ஸ்டார்ட் பண்ண சொல்ல போகிறேன். உங்களுக்கு யூடியூப் சேனல் வருதான்னு பாருங்க. இருங்க யூடியூப் அதை காப்பி பண்ணிக்கோங்க. அப்படியே இங்கே இருக்கிறத டெஸ்க்டாப் காப்பி பண்ணுங்க. உங்களுக்கு யூடியூப் லிங்க் மட்டும் போட்டுருக்கேன். இல்லை மெயில் போட்டுட்டுமா சார்? இப்போ போஸ்ட் பண்ணிடுறேன் சார்.
நம்ம ஸ்டூடெண்ட்ஸ் தாவே போகணும் ஸ்டார்ட் பண்ணலாம். ஃபார்வர்ட் பண்ணோம்.
இந்த வரேன் சார். ஓகே நீங்கள் பிரச்சனை நல்லா ரெடியாக அட்மிட் மட்டும் கொடுத்துறாங்க. யூடியூப் எல்லாம் ரெடி ஆயிடுச்சு. சார் உங்களுக்கு இந்த யூடியூப் லிங்க் போட்டுறேன். அதை நம்ம அந்த ஃபேஸ்புக் லிங்க் இருக்குல்ல இங்கேயும் போட்டு விட்றேன். ஃபேஸ்புக் லிங்க் போட்டு விட்றேன். எல்லாமே ரெடி ஆயிடுச்சு. இங்கே கொடுக்கலாம்.
Uh, Good morning, sir.
Good morning.
Okay. Start பண்றோம்ல. Okay. Uh, Good morning, everyone. I welcome you all to this webinar organized for the celebration of Heart Rhythm Week for the year 2021. I welcome our first speaker, Professor Dr. Shankar Narayanan sir, who was the former HOD of Department of General Medicine, Tanjore Medical College, and was the former Dean of Dhanalakshmi Srinivasan Medical College, and is a HOD and Department of General Medicine, Dhanalakshmi Srinivasan Medical College. Sir, I invite you to give the introduction, sir.
Professor Dr. Sajal Kumar, Chief Cardiologist from Rana Hospital, Trichy. Dr. P. Jayapandian, Senior Consultant Cardiologist and Electrophysiologist from Madurai Meenachi Mission Hospital. And our host speaker, Professor N. Ganesh. So I have to have a special mention of our cardiologist from Dhanalakshmi Srinivasan Medical College. He has done a wonderful job for the past 2 to 3 years for all interventional procedure of cardiology department, not only the treatment aspect, but also the academic side. He has organized a national conference 2 years before, and his missus, Dr. Ganavi, is very much interested in organizing this type of meet. And the recent cardiologist who joined recently, Dr. Bhavitra, and budding cardiologist from our institution, Dr. Prakash, and all the professors, assistants, and other faculty members, and my dear PGs and UGs of Dhanalakshmi Srinivasan Medical College, and other PGs from other medical colleges also. Today, this online CME organized by Department of Cardiology and General Medicine Department of Dhanalakshmi Srinivasan Medical College in view of World Health Rhythm Meet Week 2021. Electrocardiogram, the basic learning. So ECG is a very basic test which can identify any rhythm disturbance of the heart. This World Heart Rhythm Week is an annual event which will run between 7th and 13th June 2021. The aim of the World Heart Rhythm Week is to raise awareness of symptoms of heart arrhythmia in both general population as well as our medical professional. Knowledge about the arrhythmia is very, very important, and it's a life-saving procedure. So we thank our Dean and college management for organizing such a wonderful event. With this introduction, we go on to the original topic by the speakers. Thank you very much.
Good morning, everyone. I now invite Dr. Bavitra, ma'am, um, to give a talk on the basics of the ECG. She has completed her MD from SRM Medical College and has done her DM cardiology from Sri Ramachandra Medical College. Ma'am, you can start.
PowerPoint. Slideshow. Very good morning, all. Before going to my topic, I would like to thank Dr. Ganesh sir and Dr. Janathanan sir for this opportunity, and I would like to thank Medicine of HOD for introducing us. Thank you so much, sir. And the topic given to me is basics of electrocardiogram, and I was told this talk would be for uh, the students who are going to be introduced to ECG and who are new to ECG. So I want to make it damn basic, so you would come out of the fear. See, even I had this fear when I first saw the ECG. I don't know what is happening inside, just lines and curves. So I want the junior students to come out of the fear. So mine is going to be very basics. So going to my topic proper. I know I just want to give some history about this great man. This lecture would be incomplete without showing some tribute to this man who is Sir Willem Einthoven. He is a Dutch physician and physiologist. And he had given us this great baseline electrocardiogram, and he has invented electrocardiogram in 1903, and which has remained the most basic and gold standard investigation and even life-saving, where in case of acute coronary syndrome or an arrhythmia. And it's been the most basic gold standard investigation for nearly about 100 years. It is 10 decades till now, and there is no change. So he has received a Nobel Prize for the same in 1924. And we could see some machine next to him. This is a string galvanometer with which he has used first to record the electrical activity of the heart. So this was the first ECG taken by Einthoven in 1902. Even I was questioned when I was a UG or PG student, why is the ECG curves are named as PQRST and is this not ABCD, which is the initial alphabets? When I got this picture, I came to know the figure 1, which shows ABCD in the initial thing. This is because these are the uncorrected wave which Einthoven got it initially. So he superimposed mathematically corrected wave, some mathematical correction for this curves, and he labeled PQRST, and it's still in debate. It is because he used PQRST since it is the center of the alphabet, that is the middle of the alphabet, but I'm not very sure if it is true, but it is still in debate. Before going to basics, I just want to show you this ECG. If some intern or some PG would have sent me the ECG, I would have told, oh, come on, we'll thrombolyze the patient, because there is more of ST elevation, everything like that. But ECG alone should not be used for your treatment. as all the professors will agree, any clinical details and clinical findings, clinical history of the patient is very, very important before you would like to treat the patient. So this ECG, I've taken this from American Heart Journal. This patient has come with fever and diagnosed to have dengue perimyocarditis. So this global ST elevation is secondary to dengue perimyocarditis. So we can't just treat with one baseline investigation, seeing the changes and doing that. So most important thing is the clinical findings and clinical history. For the past 1 year, but stethoscope we are using little lesser than how we used before because of this COVID. We hope will come back again to normalcy. So before we are going into this was an animation, it's not playing, sorry. So before going into anything, let us see. We have to know about this conduction system so that we should correlate with all the curves and lines which we see in the ECG. So we should be more into the conduction system. We should know everything about the conduction system, which is the base for this ECG. What is an electrocardiograph? Electrocardiograph, it is a machine which records the electrical activity of the heart. And what is electrocardiogram? It is the recording, the electrical activity of heart, recording of the electrical activity of heart, which we get in the ECG paper. So what properties that heart has? It has two properties, one electrical property as well as the mechanical property. The electrocardiogram, it is the study of the electrical property of the heart, and the ECG will tell you how the electrical stimulation of the heart is produced. What all you can see from a ECG. How the electrical stimulation of the heart is produced, and where, at what frequency it is produced, and at what pathway is it traveling, and at what speed is it traveling, and the time of reaching the cardiac myocyte. So, and how the cardiac myocyte responds to it. How the millions of ventricular cardiac myocyte is responding to the initial stimulus started from the conduction system. That is very important to know what is this P, what is this QRS, what is this T, and what are these lines stands for, and that is very, very important. So, move agla sir.
ஆமாம் சார் டாக்டர் கடை கொடுக்குறோம்
PPT open பண்ணல, sorry. Sorry for the trouble.
என்ன சார் பண்ணணும் சார் ஏன் சார் தலை கொடுக்கணும் எங்கே இருக்கு இல்லை சாப்பிட சொல்லி ஒரு டைம் எடுத்துட்டு வரணும் சரி வரும்
Sorry for the trouble. And this is the electrical conduction system of the heart. The animation is not playing, I don't know why. The electrical conduction system of the heart is produced from the primary pacemaker. The primary pacemaker is the SA node. Why is it called a primary pacemaker? Because of its ability to produce the fastest and spontaneous impulses than any other area of the heart. Hence it is called the primary pacemaker. So it causes depolarization and automatically it starts from the resting membrane potential. I think you all would have known what is this. This is the action potential. This is the SA node action potential. So what happens is it automatically starts from the resting membrane potential and reaches the threshold potential, and it comes to rest spontaneously, and it fires immediately, and next action potential starts. So it is called as the spontaneous, since it is causing diastolic spontaneous depolarization, it is called the primary pacemaker of the heart, and it has the most steepest and fastest electrical stimuli ever than when compared to the other conduction areas of conduction system. So next would be, there is a primary pacemaker. As I said, it is SA node. Is there anything called a secondary pacemaker? Yes, there is secondary pacemaker, which is located at the AV junction. SA node is located at the vena cava right atrial junction, from where the depolarization begins. The electrical impulse begins, and it travels through the internodal and interatrial pathway. These tracks travel, and it comes to the AV node. So the secondary pacemakers are located two areas. One is at the AV junction and another at the ventricular region. So one is at the AV junction and another at the ventricular junction. So secondary pacemakers can also produce spontaneous impulses as like primary pacemaker, but when it takes up, when the primary pacemaker fails. So in condition, if the primary pacemaker fails, the secondary pacemaker take overs for spontaneous impulses, and it prevents asystole for the patient. So that is very important. So from the AV node, the impulses passes through the internodal pathway. From SA node, it passes through the internodal pathway as well as through the depolarization of atrium to the AV node, and then the impulses delays in AV node because of the effect of ventricular contraction. Is this AV delay very important? Yes, this is very important, because that is responsible for the powerful ventricular contraction. It depends upon the ventricular contraction depends upon, and this powerful ventricular contraction depends upon the end diastolic fiber length. So greater the end diastolic fiber length, the good subsequent contraction will produce. Hence, atrial contraction, which is called the atrial contraction, which happens in the last phase of the diastole in cardiac cycle, is most important because it is called the booster pump mechanism, and it is responsible for about 30% of cardiac output. Hence, it helps in the extra length of the end diastolic fiber, and that is the last phase of diastole, as it said, in the cardiac cycle. So the primary pacemaker produces the impulse at higher rate of 60 to 100 per minute, whereas the secondary pacemakers at the level of AV junction, it is 40 to 60 per minute, whereas at the level of ventricle, it is 20 to 40 beats per minute. So this depicts what is this is the AV delay, which is important to complete the booster pump mechanism or atrial contraction. Also, it prevents, and this booster pump mechanism and this AV delay is represented in ECG as PR segment. I'm saying PR segment, not PR interval. This is PR segment. So AV node delay is also important for one another thing, is like in case of patient is having supraventricular arrhythmias, such as in case of atrial fibrillation, the atrial rate will be more than 300. So this AV delay, what it makes is, it prevents the ventricle from higher rate of the atrium during supraventricular arrhythmias. So not all 300 would be transmitted to the ventricle. So it prevents ventricle from this fast rate. And this AV delay is depicted in ECG as PR segment. Note, it is PR segment, not PR interval. So this shows the conduction velocity or speed at which the impulses are transmitted. The ventricular muscle and the atrial muscle conducts at the speed of 0.5 meters per second, whereas AV node with so much lower speed at 0.05 meters per second, and at the level of Purkinje fibers, it is 4 meters per second. This speed is about 10 times than that of the atrial muscle and ventricular muscle, and more than 100 times than that of AV node. Hence, these fibers and these conduction systems are called as the specialized conduction system of heart. So, speed at which the impulses are conducted is the ability to spread the impulses at a very high speed or rapid speed. After AV node, SA node impulses from SA node through interatrial tract, it reaches the AV node where there will be an AV delay, as I told why there is an AV delay and how it is seen in ECG. Then through the bundle branch, it gets divided into right bundle and left bundle. Right bundle supplies the right ventricle and left bundle is further, due to increased muscle mass, the left bundle is further divided into left anterior vesicle and left posterior vesicle. Further, it is divided into two as left anterior vesicle and left posterior vesicles. These vesicles are divided into Purkinje fibers further, and these Purkinje fibers are millions and it supplies each of the cardiac myocyte. So these are called specialized cardiac system. Why? Because as it conducts at very high rate. Nearly about 300 billion of ventricular myocytes are activated within a matter of 0.8 second, which is the duration of ventricular depolarization, and this is seen as QRS in ECG. So the specialized cardiac conduction system is very important as it conducts at very high rate. So each and every impulses originated from SA node will reach each and every ventricular myocyte, the billions of ventricular myocyte which is located through the Purkinje fibers. Hence, these are the specialized cardiac fibers, specialized cardiac conduction system of heart as it conducts at very high rate. So what is this? This is AV conduction time from SA node to AV node where there will be AV delay. Cardiac impulse conducts at 30 millisecond. After creating an AV delay of 130 millisecond, it reaches the cardiac myocyte at 30 millisecond. So the total AV conduction time will be less than 200 millisecond. That is the PR interval. So I would like to summarize. The SA node is the primary pacemaker, and through three internodal pathway, atrial contraction and atrial contraction, the impulses pass through the three internodal pathway as well as from the atrial contraction or atrial depolarization. AV nodal next conducts to the AV node where the AV nodal delay takes place. Then the impulses are rapidly spreading through the specialized cardiac conduction system. I have told you why it is specialized cardiac conduction system. Ultimately, it is the electrical impulse which convert them, and this electrical impulse is converted into the mechanical energy and which helps in the heart contraction. So, regarding depolarization and repolarization, what is depolarization, repolarization? Throughout the ECG, we'll hear these terms. Even I was worried during after hearing all these terms. Once I came to know what is that, it was very easy. So the ventricular myocyte at resting state, it is called as a polarized cell. Polarized cell is ventricular myocyte at resting state. What happens in resting state? The inside of the cell, that is the ventricular myocyte, inside will be more of negatively charged, and outside of the cell will be more of positively charged. So sodium ions will be more of outside. Yes, sorry, sir, sorry. So this is how the cardiac myocyte would respond to this impulse, and it is called depolarization and repolarization. So what is a polarized cell? Polarized cell is a cell at resting state. So ventricular myocyte at resting state, what happens is inside of the cell will be more of negative ions, and outside of the cell will be more of positive ions, more of sodium ions outside and negative ions within. So what happens then once the impulse is being formed, then it has to go to the depolarized state or contraction. What happens now? All the positive ionic channels like sodium channel gets opened. This is I have just shown an action potential nearby to tell you what is happening. So this is the resting stage or polarized stage, where resting membrane potential is in negative side. So once impulse starts, it gets to get contract immediately, and what it happens? Depolarization takes place. So it becomes positive immediately. Now what happens? More of sodium ions to the positive ionic channel enter into the cell, and negative ion leave the cell and stays outside of the cell. Now the cell becomes in depolarized state. This sodium ion is responsible for this initial phase. So next what happens? This depolarized state has to be maintained in a plateau phase. This is maintained by another positive ion called influx of calcium ion. Influx of calcium ion helps in maintaining the cell to be in depolarized state. Then what happens? Again it has to be re-established to a polarized cell. That is, it has to go to the resting state again. So now what happens? There will be efflux of positive ion, that is potassium ion, from inside to outside. So again, like in polarized state, what becomes is the inside the cell becomes more of negative, and outside the cell becomes more of positive, and again the myocyte cells becomes polarized state, that is resting state. How can we correlate this with ECG? So this initial sodium influx and the depolarization of initial depolarization of the ventricle is seen in ECG as QRS. So ion responsible for this is sodium. So sodium ion. So next, this depolarization state is being maintained by influx of calcium ion. This is plateau phase. So this is depicted in ECG as this ST segment. So this ST segment is very important, as we know. We have seen all in ACS. So what happens next? The more of positive potassium ion is leaving from inside of cell to outside. So more of positive potassium ion is leaving from inside of the cell to outside, resulting in ventricular depolarization, which is depicted as T wave in ECG, following which from the ventricular repolarization to ventricular repolarization is the TP segment. So this repolarization of ventricle is depicted as QRS in the ECG, and this maintenance of this plateau phase, which is mediated by influx of calcium ion, is depicted in ECG as flat line, which is the ST segment, and this influx of potassium ion from inside to outside and creating negative polarity is depicted as T wave in ECG. This is going to be the basic. So I have shown it with I've told you ECG more towards physics. So there should be some positive and negative ions, and positive and negative circuits. It should be connected somewhere to the body, and it should create a circuit to get these electrical activity on an ECG paper. So what is seen is, how will we record this depolarization and repolarization wave is, initially in the ventricular myocyte, there will be influx of more of positive ion and efflux of more of negative ion, which results in initial positive depolarization wave, after which it is maintained by influx of calcium ion, and by efflux of potassium ion, the next ventricular repolarization takes place. So I had this doubt, if depolarization causes a positive wave, then the repolarization should be causing a negative wave. But when we think of ECG, QRS and T wave are in the same direction. As I told you, QRS is ventricular depolarization and T wave is ventricular repolarization. But what here is, QRS is in same direction of T wave. This is because depolarization takes place from inside to depolarization takes place from endocardium to epicardium, whereas repolarization takes place from epicardium to endocardium. So both depolarization and repolarization takes place in opposite direction. That is the reason for same direction of QRS and T wave. So what happens initially is atrial depolarization is initiated by SA node, which causes P wave in ECG, and with atrial depolarization gets complete, the impulse is delayed, and this AV delay is seen as PR segment in ECG, and ventricular depolarization begins at the apex, causing the QRS complex, and during the same time the atrial repolarization occurs, but atrial repolarization is within the QRS, and then ventricular depolarization is ventricular depolarization gets complete, which is seen as ST segment, and followed by ventricular repolarization, which begins and it causes the T wave. So this completes the PQRST in ECG. So these are the basic waves and interval which we all should know. Basically 3 waves, PQRST, and 3 isoelectric line, that is PRST and TP segments, are very important. So going to the next thing, lead system is very important. Why? Because the correct lead placement is very important for otherwise there will be some misinterpretation of ECG. So what is electrode? Electrode is nothing but the conductive metallic plate or pad that is attached to the skin and enables the recording of electrical activity of the heart. And what is lead is the imaginary line along which the electrical activity is being measured. So everything involved in leads, it is physics. So electrocardiograph is a galvanometer, hence something should be connected to the positive pole and something should be connected to a negative pole. This will complete the circuit and to get the recording from electrocardiographic machine. So each lead has got a positive pole and also it is connected to a negative pole. So I had this doubt, why the electrodes are in limbs? We are placing electrodes in the limb when heart is in the thorax. If we want to do an ultrasonogram of abdomen, we'll do it in the abdomen, not from the limbs. It is because the SA node activity is not only confined to the heart. The electrical charges are taken throughout the body by blood. So through the lower limb lead, we will know what is happening in the inferior surface of the heart, and through the upper limb lead, we'll know what is happening in the medial and lateral surface of the heart, and so on. So we utilize this property. So we will utilize this property of the heart. So basically the ECG leads are 12 lead ECG system. We'll have 6 limb leads or frontal plane leads and 6 precordial chest leads or horizontal plane leads. So these are further classified as bipolar leads and unipolar leads. The bipolar leads are 3, which is standard limb leads. Why standard is very important. It is 1, 2, and 3, and unipolar leads are augmented limb leads. Why augmented? I'll tell you why. And it is AVR, AVL, and AVF, and chest leads V1 to V6 are unipolar leads. So there are totally 3 bipolar lead and there are 9 unipolar lead. So what are bipolar lead? In bipolar lead, a positive pole and negative pole is connected to different parts of the body. That is, one arm will be connected to a positive pole. For example, this is lead 1, this is lead 2, and this is lead 2, and this is lead 3. Why it is standard limb lead is we are not going to augment anything here. One will be connected to a positive pole and another will be connected to a negative pole. So this will form an horizontal line, and lead 2, in case of lead 1, what happens is In case of bipolar pole, we will connect one arm to a negative pole. So we'll connect right hand to a negative pole and left hand to the positive pole, which creates an horizontal line, and we'll see whatever is happening from right to left surface of the heart. So, what is unipolar lead is, it will see only one aspect of the heart. So, the center of the heart, which is termed as Wilson central terminal. From here, the other leads are connected as negative pole, and we'll see what is happening within this. So what happens is, from here we'll see what is happening within this. But what happened is, since these leads are far away from the heart, we got very low voltage complexes. So what Ethoven did is, he made the arm of interest. If in case of AVR, it is right arm as negative pole, as positive pole, and he made other arms as negative pole, and he used the same. So in case of lead 1, we connect the right arm to a negative pole and left arm to positive pole, and line of imagination is horizontal, left to right, so horizontal lead. In case of lead 2, we'll connect a negative pole to the right arm and positive pole to the left foot. So line of imagination is from inferior to left. In case of L3, we'll connect a negative pole to left arm and positive pole to left lower limb. So the line of imagination is inferior and right. So these are bipolar leads. This bipolar leads forms the Ethoven triangle. So lead 1 shows what is happening horizontally. So leftward and inferior will be lead 2, and rightward and inferior will be lead 3. So lead 2 and lead 3 are basically inferior leads. Next would be unipolar lead. So in unipolar lead, as it says, center of heart is the Wilson's heart terminal, which is all 3 limbs are connected to negative pole. To augment, the limb of interest will be made as positive pole to get a better QRS complex. So yeah. So regarding lead AVR, it is AVR is right. AVR sees the right superior surface of the heart, whereas AVL sees the left superior surface of the heart, whereas AVF sees the vertical down inferior leads. So we have seen 3 inferior leads, which is 2 AVF and lead 3. So this all forms the Ethoven triangle, which is more important for the axis. And placement of chest leads is very important, where misplacement of leads happen commonly. So from angle of Lewis down below 4th intercostal space, 2 spaces below, we have to place lead 1 in right 4th intercostal space goes to sternum, and left 4th intercostal space goes to sternum will be lead 2, and lead 4 will be in the left 5th intercostal space in the mid clavicular line. Only after that you have to place the lead 3 between lead 2 and lead 4, and lead 5 will be in the anterior axillary line, and lead 6 will be in the mid axillary line. So all these chest leads sees the anterior surface of the heart. So what is right-sided leads? Where is it is important? Right-sided leads are important when you have to see for the right ventricle and right side of the heart. Same like left, but the leads have to be placed same like left, but on the right side. V1 and V2 will be on the same side, whereas V3, V4, and V5 and V6 will be on the will be placed on the right side in the corresponding place. And for the posterior, for posterior wall infarction is very important. So we have an extra V7, V8, V9 leads kept posteriorly in the posterior axillary line and mid scapular line and paraspinal line. So what does it say? From all this, from these leads, what surfaces of the heart can be seen? From lead 1 and AVL, it is high lateral wall, and V5 and V6 for anterolateral. So all these are lateral wall. Lead 1, AVL, V5 and V6 all sees the lateral surface of the heart, high lateral and anterolateral. Lead 2 then comes the AVF, then lead 3 is the inferior surface of the heart, and V1 sees the right ventricle, V2, V3 and V4, interventricular septum and anterior wall, and reciprocal V1 and V2 for posterior surface of the heart. So what all the important measurements we know of? So this ECG grid shows 5 large boxes, and within the 5 large boxes there is 5 rows of small boxes and 5 columns of small boxes. So what important is the horizontal line shows the time or speed, whereas the vertical line shows the amplitude or height. So so each large square is further divided into 25 small squares, that is 5 rows and 5 columns, and each small square is 1 millimeter in length and 1 millimeter in width. So normally the speed of the ECG should be set at 25 millimeters per second, and this should be checked initially when you read an ECG. The first thing to be seen is the speed and the standardization to avoid any misinterpretation of ECG, and this is equal to 25 small squares per second, and 5 large, for 1 second it is 5 large square and it is 25 small squares. And going to the next, what does the horizontal line represents? It is the time. So 1 small square will be equal to 1 by 25 second or equal to 0.04 seconds. So 1 small square speed is 0.04 second, and 1 large square is equal to 0.2 second. And vertical line, it represents, as I told, it represents the voltage. So traditionally, every 10 small squares or 2 large squares will be 1 millivolt. So it is very important to see if the standardization is correct from the recording we got. So these are the basic waves and segments and intervals in ECG we should see of. And even this shows the same, the basic P wave, PR segment, QRS complex, where is the ST segment, T wave and U wave. I have already explained what is the initial wave, what is the initial segment, individual segment, and what is the individual interval, and what is the individual complex is from. So going to first wave, which is the P wave. Anatomically, right atrium and left atrium, it is positioned opposite to each other. So right atrium is right and anterior, whereas left atrium is situated left and posterior. So the first atrium to be activated is the right atrium, and only then the atrial depolarization will travel leftward and backward to depolarize the left atrium. So for seeing P wave, the most important lead is lead 2 and V1. So you have to see for P wave in lead 2 and V1. In lead 2, which is an inferior lead, so both right atrium and left atrium impulses will travel towards the lead. So both the initial right atrial activation and left atrial activation will be positive, whereas in case of left atrial depolarization, both will travel in opposite direction. So right atrium will travel towards the lead, so it causes initial positive deflection, whereas left atrial depolarization takes place after right atrial depolarization backwards. So it will be negative deflection in ECG. Hence, this is referred to as biphasic P. Hence, it is referred to as biphasic P. So this one I have shown to show this is a normal ECG with a biphasic P in V1, which is seen here. This is right atrial depolarization, this is left atrial depolarization, and a positive P here, which denotes both are in same direction. So to see for the P wave, it is commonly seen in lead 2 and V1. Next we'll go to normally the P wave should be less than 2.5 small squares vertically as well as horizontally. If it is more than 2.5 small square vertically or more than 0.1 second, it is called tall P wave. So if the amplitude is normal, but it is wide, it is referred to as tall T waves. So increased amplitude indicates right atrial enlargement. Increased amplitude indicates right atrial enlargement, and increased duration or wide P wave, it indicates left atrial enlargement. If there is increased amplitude and duration, it is referred to as biatrial enlargement. So going to the So going to next segment will be regarding the ST segment. This is more important for ACS. This is due to the influx of calcium ion. So duration is 0.04 second, and the point at which the QRS meet the ST segment is the J point. So it should be seen how much is the deflection above or below. This elevation or depression is important to note if there is any for ACS. So next will be the T wave, which is ventricular repolarization. So the T wave goes with QRS complex. It will be of same direction with the QRS complex. This is because, as I told, the direction of repolarization and depolarization is opposite. Hence, it will be of same wave, same direction, and with its amplitude, which means if QRS is small, T will be small. The amplitude will also be similar to that of the QRS. The T wave is compared with always with preceding QRS. So if it should be at least 20% of the preceding R wave. So if preceding R wave is not more than 40%, or if it is less than 20%, then it is abnormal. So this is regarding T wave, and U wave is repolarization of the Purkinje system. So this will also go with T wave. If there is inversion of T wave when compared to U wave and compared to T wave, it is more towards CAD, and prominently seen U wave can be seen in some dyselectrolytemia such as hypercalcemia or any hypokalemia, or even normal variant post exercise. So next will be important thing is the QT interval. QT interval is calculated from the beginning of Q to end of T. This indicates both D and depolarization as well as the repolarization of the ventricle. Corrected QT for the heart rate is very important, because bradycardia can cause long QT and tachycardia can show a short QT. So heart rate should be corrected with this formula called Besset's formula, which is this insertion of T wave is very important. So there will be an isoelectric line, and beginning of Q to end of T, we should calculate how much is the small square, and the square root of RR interval should be taken to get the QT interval. So long QT interval can be seen in several congenital long QT syndromes are there, which will be very interesting, and some drugs can cause long QTC in this pandemic time. Azithromycin macrolides can cause long QT, as well as electrolyte imbalances can cause long QT. And short QTs are common with digoxin and hypercalcemia. So any patient who has come with syncope or history of near syncope, QT interval calculation is very important to rule out any arrhythmia. So these are the causes of prolonged QT interval. That is more than, if QT interval is more than 440 in male or more than 460 in female, it is called as prolonged QT interval. So these are the reasons, such as electrolyte imbalances, any hypothermia, post-cardiac arrest, certain medications, all can cause prolonged QT interval. So next, most easiest, and what we take, once we go to read about ECG, what we initially see is about the heart rate calculation. So first thing to be make sure is if the speed of the ECG is 25 millimeters per second. Then if it is in normal sinus rhythm, that is the P wave should follow QRS and equal to P wave rate should be equal to QRS rate. So take the lead where the QRS is seen very good, where it is very much eligible, and 2 adjacent QRS should be taken, not the different lead. So this T300 is number of large squares per minute. This 1500 is number of large small squares per minute. So this is the standard formula. For the rate we calculate the RR interval, number of 300 divided by number of large squares, or 1500 divided by number of small squares. This is for regular rhythm. If the rhythm is irregular, then we have to take 10-second rule. That is, ECG will, the whole strip will be for 10 seconds of rhythm per page. So you have to count number of hours per ECG, the total ECG number of hour, then multiply by 6, then we'll get a rate for irregular rhythm. So to say if ECG is in normal sinus rhythm, what all you have to get is the rhythm should be regular, each QRS should be preceded by a P wave, and the axis of P wave should be normal, as I told in lead 2 and V1, and most appropriately it should be positive in lead 1 and lead 2 and inverted in AVR, and the PR interval should be constant and QRS complex should be narrow. Thank you. Thank you so much for the opportunity, sir.
Dr. Ganesh, can I start my presentation?
Okay. Thank you very much, Bhavitra ma'am, for the orientation into the basics of ECG. It was very simple and easy to understand. I now welcome our next speaker, Dr. Sendil Kumar sir, who has done his UG from Annamalai University, and his PG from Sri Ramachandra Medical College, and his DNB from Apollo Hospitals, Chennai, and he has also done MNAMS in cardiology, and he's been awarded with the topmost degree in cardiology, fellow of the society, fellow of the American College of Cardiology, and he's also a fellow of the Society for Cardiovascular Angiography and Intervention. Sir has several academic achievements, like he was the first person to do drug coating stenting in Trichy. He has done a pacemaker implantation for a 83-year-old female dextrocardiac female patient, and he was the first person to do IVC filter in Trichy. Sir has also been conducting teaching and training programs for peripheral doctors for more than 10 years, and sir has received various state awards like the Sevai Sudar Award 2008, Sevai Tilagam Award 2009, and he has been given the Tamil Nadu State Best Doctor Award 2009 by the Indian Medical Association, and he has also got the Guinness World Record 2017 for giving the largest awareness lecture on organ donation. And sir has also conducted several socio-medical activities. He has various publications and presentations under his name, and the achievements and contributions by sir in the field of cardiology are truly inspiring for young doctors like us. Sir, I welcome you to address the gathering on ischemic heart diseases, sir. Thank you very much, sir.
Thank you for the kind words. Respected Dr. Ganesh, respected faculty members, distinguished participants, senior members, students, and my dear friends. At the outset, I would like to thank Dr. Ganesh for having given me this excellent opportunity to speak in this conference, and I would like to congratulate him also. Dr. Ganesh has given me 25 minutes to 30 minutes talk. I should do justice in this 25 minutes to 30 minutes. He said both CRRIs and PGs will be there. So certain areas will be in a very basic level, and in certain areas it will be in a slightly higher level for the PGs, for the benefit of the PG students. But I assure you and guarantee that at the end of this 25 minutes talk, definitely you will have at least 10 carry-home messages from my talk, my dear friends. So before going to my crux of my presentation, I will start with basic 4 points which you should do when you deal a patient with chest pain in casualty. When you are dealing a cardiac patient in casualty, the commonest complaint for which a patient comes to casualty is chest pain. Remember 4 points. Hope my slides are visible.
Yes, sir. Yes, sir. Visible.
Slides are visible.
Yes, sir. Visible.
Oh, sorry. So let me start with the 4 points. Point number 1. One thing which you will know but you will forget is, do not forget to compare with the previous ECG when a patient comes with chest pain to casualty. This is the ECG of a patient coming with chest pain to casualty. This is taken when the patient had chest pain. This is the baseline ECG. You can see the T-wave inversion in the baseline ECG. But when the patient comes to casualty with chest pain, this patient had an upright T-wave and this ECG looks near normal. So you will be falsely sending the patient that the ECG is normal. So this is called a pseudo-normalization of T-wave. So the point number 1 is always compare with the previous ECG. Point number 2. One thing which you should not tell the patient attenders, in a diabetic patient or patient with multiple coronary risk factors, do not tell the attenders that everything is normal, even if the first ECG is normal, without taking subsequent serial ECGs. I underline the statement, without taking subsequent serial ECG, do not brand the patient as normal. This is an example of such a patient. Patient came to casualty at 8:50 a.m. in the casualty with chest pain. ECG is near normal. But subsequently, 10 minutes after admission, patient had severe chest pain again. ECG taken, revealing a ST elevation in anterior leads, regarding which I will describe in detail in the subsequent slides. This is just to highlight that with one ECG, do not brand that everything is normal. Then the patient also will be in soup and you will also be in soup. So point number 3. One thing which you should not do when a patient comes with chest pain to casualty, do not do troponin T to rule out cardiac cause for chest pain if the onset of pain is less than 6 hours. So if you do it within 6 hours, you will have a falsely negative trop T and you will miss a cardiac patient with cardiac chest pain. Point number 4, one thing which you should always do, always admit a patient who comes late in the night with chest pain, even if the character of the pain is atypical and even his ECG is normal. At least give an option of admission. With this basic points of 4 points, how to deal with the patient with chest pain and casualty, let me go to the next stage of my presentation. Friends, can you guess what this picture in the slide? This is Lennox invented stethoscope on day 1. Lennox invented the stethoscope. Subsequent evolution of the stethoscope, tubing came, double tubing came, diaphragm came, Bell latest decorated stethoscope, golden stethoscope, gem-studded stethoscope, diamond-studded stethoscope, and stethoscope with which you can record the murmur, connected to cell phone, and and the latest equipments you can connect and you can record the murmur. So likewise, the evolution of BP apparatus was like this: mercury, non-mercury, digital, and likewise ECG machine, starting from the basic ECG machine to the latest computerized ECG machine. The point to be highlighted here is, as on date, I underline the statement, as on date, the gold standard diagnostic modality and tool to diagnose an acute MI is still an ECG. So ECG is a must. So coming to my presentation, ischemic heart disease, which includes chronic stable angina and acute coronary syndrome. I'll be speaking about mainly acute coronary syndrome because these changes are mainly seen in this entity, acute coronary syndrome. The term acute coronary syndrome includes 3 conditions, namely unstable angina, non-ST elevation MI, and ST elevation MI. What are the parameters, basic parameters to be seen in an acute coronary syndrome? There are only 3 parameters you should see. One is ST segment, second is T wave, and third is Q wave. What are in these 3 parameters, what are the things you have to look? ST segment, see whether the ST segment is elevated or see whether the ST segment is depressed or ST segment is normal. Second parameter, as I told, T wave, whether T wave is upright or inverted. Third is whether the Q wave is present or not, absent or present. So having seen the basic 3 parameters in the ECGs, that is ST segment, T wave and Q wave, we'll go to the next stage of my presentation, that is ST elevation MI. What are the basic types of, how do you classify ST elevation MI? It can be classified based on territory and based on the age of MI. Based on the territory, ST elevation can be classified as anterowall MI, anteroseptal, anterolateral, extensive anterior MI, lateral and high lateral MI. How do you classify inferior wall MI? It can be classified as inferior wall MI, subtypes or inferolateral MI, inferior wall MI with RV extension, and inferior wall MI with posterior extension. So, to simplify the topic of classification of acute MI for the benefit of CRRIs, just take, there are only 2 MIs. That is, one is anterowall MI, second is inferior wall MI. So, having seen the classification of MI based on territory, I will go to the next variety of classification of MI based on the age of MI. It can be hyperacute MI, it can be acute MI, it can be evolved MI, and it can be old MI. So having seen the classification of MI based on territory and based on the age of MI, likewise hyperacute, acute, evolved and old MI, we will go to the next stage of my presentation. What are the ECG leads you should see in an acute ST elevation MI? To simplify our topic for the benefit of CRRIs, there are 2 sets of leads which you should focus when a patient comes with ST elevation MI. Set number 1, V1 to V6, that is precordial chest leads. Set number 2, lead 2, 3 AVF, which is the inferior leads. So 2 sets of leads, V1 to V6, and 2, 3 AVF limb leads, that is the inferior leads. So what are the possibilities of ST segment elevation when you deal with an anterior wall MI? So ST segment elevation, if you have it in V1, V2, it is septal wall MI or anterior wall MI. V1, V2, V3, V4, if the patient has ST elevation MI, it is anteroseptal MI. If the patient has ST segment elevation in V1, V6, it is anterolateral MI. If the patient has ST segment elevation in V1 to V6 and L1 AVL, which is high lateral leads, that is extensive anterowall MI. If the patient has ST segment elevation only in V5, V6, it is lateral wall MI. And if the patient has ST segment elevation V5, V6, L1 AVL, then that patient has a high lateral MI. So having seen the possibilities of ST segment elevation in varieties of anterowall MI, let us go to the ST segment elevation in inferior wall MI pattern. So if the patient has ST segment elevation in lead 2, 3 and AVF, it is inferior MI. If the patient has ST segment elevation in lead 2, 3, AVF, in addition to that, if the patient has ST segment elevation in V5, V6, then it is inferior lateral MI. Next possibility in an inferior MI, as the previous speaker had excellently highlighted about the importance of right-sided leads. That is, in an inferior MI patient, always you should take right-sided leads. If the patient has inferior MI, that is ST segment elevation in 2, 3 AVF and ST elevation in V4 R, then that patient has an additional RV extension MI in addition to inferior MI. Last variety in an inferior MI is inferior MI with posterior extension, where you have ST segment elevation in 2, 3 AVF. In addition to that, ST depression is seen in V1, V2. That patient has an inferior MI with posterior extension, which is called as mirror imaging, regarding which I will explain in the subsequent examples when we see the ECGs in depth. So, for the benefit of CRRAs, to simplify our topic, I told you there are two MIs, anterval MI and inferior MI. If there is ST segment elevation in V1 to V6, it's anterval MI. If there is ST segment elevation in 2, 3 AVF, it is inferior MI. So, for the past 5 to 6 minutes, I was speaking about the ST segment elevation, ST segment elevation, ST segment elevation. If you have in these leads, where should you see ST segment in the ECG? So, in this slide, the ST segment starts from the ending of S wave to the beginning of T wave. In other words, the J point is where the S wave joins the ST segment and the ST segment ends at the beginning of T wave. So this area is the ST segment. You need to concentrate the J point, that is the junction of the S with the ST segment. So this slide shows the normal ST segment and the ST segment elevation. So here you can see the right side of the slide, you can see the J point elevated because of the acute coronary syndrome, acute ST segment elevation MI. So when do you say that ST segment elevation is significant? So I repeated, all ST segment elevation is not acute MI, but when do you say that ST segment elevation is significant? If the patient has more than 1 millimeter ST segment elevation in limb leads, so more than 1 millimeter is more than one small square in limb leads, then it's a significant ST segment elevation. If a patient has more than 2 millimeter ST segment elevation in precordial leads, then it is a significant ST segment elevation. So having seen which is a significant ST segment elevation and having seen the importance of J point and having seen the two types of MI, anterior and inferior, let us go to the examples of anterior on the ECGs. This is a classical example of a hyperacute anterior wall MI. Here you can see the gross ST segment elevation with tall T waves. So I underline the statement, if a patient has ST segment elevation with tall T waves, that patient has a hyperacute MI. So this is a classical ST segment elevation in tall T waves seen in V1 to V4. This is anteroseptal MI, hyperacute MI. Yet another ECG of a ST segment elevation V1 to V6. This is anterolateral MI, acute anterolateral MI. You can see the ST segment elevation V1 to V6. This is an example of an evolved anterval MI. Here you can see the ST normalized and T wave inversion occurred. This is an evolved anterval MI. So T wave inversion in V1 to V5. So anterior evolved MI. This is an example of an anterolateral MI. So here you can see the V1 to V6 ST segment elevation. This is an example of an anteroseptal MI. Here you can see the ST segment elevation. As I told you, more than 2 millimeter in precordial leads, classical anteroseptal MI. So ST segment elevation in V1, V2, V3 and V4. In this patient, you have a ST segment elevation V1, V2, V3, V4, V5, V6. In addition to the precordial leads, friends, if you focus here in lead 1 and AVL, there is a more than 1 millimeter elevation in addition to the anterior ST segment elevation. So this is a anterior wall MI with high lateral extension. So lead 1 AVL or high lateral leads. So lastly, another example of anteroseptal MI. Here you can see the ST segment elevation V1 to V4 signifying this patient having an anteroseptal MI. So we have seen the examples of various varieties and possibilities of ST segment elevation which you can encounter in an anterior MI. So we will go to the next subset of inferior MI patients. So as I told you, inferior leads are lead 2, 3 and AVF. This is a classical inferior MI. As I told you, in limb leads, to say it as an ST segment elevation is significant. 2 contiguous leads more than 1 millimeter. So lead 2, lead 3, lead 3 and AVF, inferior MI, acute inferior MI. So this is yet another patient with acute inferior MI. So ST segment elevation, lead 2, 3, AVF. In addition to that, patient is having ST segment elevation in V5, V6. So as I told you, lateral leads involved in addition to the inferior wall MI, that is inferior lateral MI. In an inferior MI patient, you can have a reciprocal changes. So that is ST segment elevation in inferior leads with AVL showing ST depression. So in this ECG, it is depicted classically. So 2, 3 and AVF, the patient is having ST segment elevation. In addition to that, you can notice the ST segment depression in AVL, which is the reciprocal change. Yet another patient with reciprocal change, lead 2, lead 3, lead AVF, you have an acute inferior MI and ST depression noted in AVL. This is reciprocal change in an inferior MI patient. In addition to that, if you notice here, if you concentrate in anterior leads, there is a gross ST depression. As I told you, in an inferior MI patient, if you have ST depression in a posterior, in V1, V2, that patient has an inferior MI with posterior extension. This is called as a mirror image sign, because if you turn the ECG upside down, this ST segment depression will be seen as an ST segment elevation. So any MI will have, all MIs will have ST segment elevation except posterior MI that is associated with inferior MI. You have ST depression in V1 and V2 that is called as inferior MI with posterior extension. So as I told you, any patient with inferior MI, you have to take a right-sided lead. So this is a right-sided lead ECG. So the lead to be concentrated in the right-sided lead is only one lead, that is V4. So here you can see, in addition to the inferior MI, lead 2, lead 3 and AVF, you have an ST elevation in V4 that is called as an inferior MI with right ventricular extension. So right ventricular MI is associated with the inferior MI. So let us see a case scenario. 65-year-old diabetic presents to casualty with severe chest pains in 6 hours prior to admission. There was no contraindication for thrombolysis because of non-availability of cath lab. The patient was decided to be thrombolized. There were contraindications were excluded, like IC bleed and bleeding tendencies. Patient was safely thrombolized with streptokinase. Here you can see the acute anterior MI, ST elevation V1 to V6. How will you assess the effect of thrombolysis or reperfusion? How will you assess the reperfusion after thrombolysis? So assessment of reperfusion is based on relief of symptoms, hemodynamic and electrical stability, reduction of ST segment. When compared with the admission ECG, it should be less than 50%, and reperfusion arrhythmias. So this is a well reperfused after thrombolysis. Here you can see the ST nearly normalized and T-wave inversion occurred, evolved anterior MI. Here, if you concentrate on the bottom of the slide, you can see in the rhythm strip, you can see the accelerated idioventricular rhythm. So signifying that it has been reperfused. But unfortunately, the patient suddenly complained of severe chest pain 10 hours after thrombolysis. ECG taken then revealed a re-infarct, acute anterior re-infarct. Here you can see the ST segment elevation again seen V1 to V6. Subsequently, he was taken up for PCA angiogram and followed by a PCA to LAD. So having seen the various types of ST segment elevation which you can encounter in an anterior MI, in an inferior MI, inferior posterior, inferior MI with RV extension, let us go to the other causes of ST segment elevation without acute coronary syndrome. It can occur in pericarditis, benign early repolarization syndrome, LBBB, and Brugada syndrome. So what do you mean by Brugada syndrome? You should develop an art of picking up rare findings also in the ECG, which can save one's life. This Brugada syndrome is an incomplete RBBB with ST elevation in V1, V2. Classical Brugada syndrome here, you can see the incomplete right bundle branch block M pattern with ST elevation in V1, V2. This patient can have fatal arrhythmias and can have a sudden cardiac death. So if you have such a finding, it is a Brugada syndrome, you need to refer him for a electrophysiological study. So pseudo ST elevation without an acute MI can occur with LBBB, which the LBBB is this ECG of a patient having LBBB, that is M pattern in V6 and W pattern in the V1. This is a close-up view of the W pattern and M pattern in left bundle branch block. This is V6 M pattern, and this is the W pattern in V1. So what if a patient with baseline LBBB develops an antero-LMI? For the benefit of the PG students slightly at the higher level, I repeat the statement. If a patient has an LBBB and that patient develops an antero-LMI, how do you diagnose? There is a Scarbosa's criteria for diagnosing acute antero-LMI in the presence of LBBB. So there are three variables to be concentrated in Scarbosa's criteria. One is ST segment elevation in concordant leads. ST segment elevation in discordant leads is the second variable, and ST segment depression in V1. What do I mean by concordant and discordant ST segment elevation? Here, friends, if you notice here, the QRS is in the same direction of the ST segment. So this is concordant ST segment elevation. I repeated, the QRS and the ST in the same direction. So in the concordant leads, if it is more than 1 millimeter, it is a significant. So that patient can have an acute antero-LMI in the presence of LBBB. What do you mean by discordant? This is discordant. The QRS is in one direction and the ST segment is in the opposite direction. So in this scenario, in the discordant leads, if it is more than 5 millimeter, it is significant. V1, there is ST segment depression. If it is more than 1 millimeter, that patient might have a antero-LMI in the presence of LBBB. So there is a scoring system in Scarbosa's ECG criteria. If the ST segment elevation is more than 1 millimeter in concordant leads, give 5 points. If the ST segment depression more than 1 millimeter in lead 1, you give 3 points. And if the ST segment elevation more than 5 millimeter in discordant, give 2 points. If it is more than 3, then that patient has an antero-LMI with LBBB. So this is an example of a Scarbosa's criteria fulfilling antero-LMI in the presence of LBBB. This is discordant 5 millimeter, more than 5 millimeter. This is concordant more than 1 millimeter. And here you can see the ST depression in V1, V2, that is more than 1 millimeter. This patient has an antero-LMI in the presence of LBBB. Benign early repolarization syndrome is a condition where you can have an ST segment elevation without, it is a benign condition, as obviously the term depicts. This, you can have a notching at the J point. This is commonly seen in young individuals. This is a benign condition. That's why I have incorporated a smiley at the J point. There is a notching at the J point, which is called as a fish hook sign. Another point to be highlighted in benign early repolarization syndrome is when the patient has a low heart rate, the notching is well seen. And when the patient has a higher heart rate in a benign early repolarization syndrome, the notching becomes less prominent. Next, ECG showing a pseudo ST segment elevation is pericarditis. Patient can have a global ST segment elevation. The point to be highlighted in a pericarditis patient ECG is in AVR, patient will have a ST segment depression and PR segment elevation. The least noticed lead in the ECG strip is AVR. So in a pericarditis, global ST segment elevation and patient will have a ST segment depression in AVR and PR segment elevation in AVR. So I have finished 21 minutes. I will just take another 5 minutes coming to the 19 minutes I have finished. I will just take another 6 more minutes in my talk. Having seen about the ST segment elevation, now we will go to the non-ST segment elevation MI. So as the name signifies that there is no ST segment elevation in this entity of patients, there is ST depression. There are 3 types of ST depression. There is upsloping ST depression, downsloping ST depression, and horizontal ST depression. Out of these 3, this downsloping ST depression is most significant. Here's the classical non-ST elevation MI in a patient with non-ST elevation MI, gross downsloping ST depression in anterior leads, severe chest pain. So patient was immediately taken for the cath lab and subsequent treatment was given. So this is yet another patient with non-ST elevation MI, gross ST depression, and you can notice that gross ST depression in anterior leads signifying an anterior non-ST elevation MI. So I have not touched about the therapeutics during my talk because this is a meet about ECG. So one slide I will talk about the therapeutic, which will be of a cariogram message, which will be useful for the CRRAs and the PGs. In a non-ST elevation MI, do not thrombolyze. In a ST segment elevation MI, you have to thrombolyze, save the muscle, save the life, and preserve the lifestyle. So by preserving the muscle, preserving the lifestyle, his life is saved, his effort tolerance is saved. But if you don't save the muscle, his life is doomed. His LV function will be like this. His day-to-day lifestyle will be doomed. So it is our duty to thrombolyze and reperfuse the occluded artery in a ST segment elevation MI. So this is the last slide in non-ST elevation MI. This shows the normal ST segment. This is a ST segment elevation MI, and this is a non-ST elevation MI. There is a ST depression with T wave inversion. So ST segment elevation, non-ST elevation MI. Coming to my last leg of my presentation, I've got another 4 to 5 minutes more. Localization of culprit vessel in an acute MI patient from ECG itself. This is for the benefit of the PG students. What do I mean by localization of the culprit vessel? From the ECG itself, you can diagnose which artery is occluded, whether it's an LAD or circumflex or RCA, from the ECG itself without doing a coronary angiogram. So you might think, what is the use of a physician to know about whether it's LAD is occluded or RCA is occluded or circumflex is occluded? So I will answer this question in this slide. There are 3 aspects of managing a patient, irrespective of whether you are dealing with a cardiac patient or an ortho patient or a urology patient, nephrology patient, whatever field may be. There are 3 aspects in managing a patient. One is you need to diagnose the disease, you need to treat the disease, and the third is you need to prognosticate and risk stratify the disease. First 2 you are doing to save the patient. Last, prognostication and risk stratification, you are doing to save your skin. So you have to save yourself and the patient also. Both the things you have to do simultaneously. That is why you need to develop an art to prognosticate a high-risk patient at the time of admission. When the patient sinks and when the patient deteriorates, anyone can tell that it is patient is becoming bad. So at the time of admission, on that juncture, you have to keep the relatives informed that you are dealing up with a high-risk patient, and the patient you have to give a guarded prognosis. How to deal with this in culprit vessel localization? That is, I will tell you, I will simplify in stage 1, 2, 3, and 4. Stage 1 is you need to know the basic coronary anatomy. There are 2 coronary arteries for the practical purpose: left coronary artery and right coronary artery. Left coronary artery, the left main stem divides into left anterior descending and left circumflex. Left anterior descending and this left coronary system supplies more than 60 to 70% of the blood supply to the LV myocardium. So the most important out of these 3 arteries, LAD, circumflex, and RCA, the LAD is the most important artery because of which it is called as the widow's artery. If this LAD is occluded, the patient will have a massive MI. So stage 2, as I told you, there are 2 MIs. Antral MI, the culprit vessel is left main or LAD. Inferior MI, it may be due to right coronary artery or circumflex. I have very simplified for the benefit of the PG students. I repeat it. If you are dealing with an antral MI, it may be due to a left main occlusion or a LAD. If you are dealing with an inferior MI, it may be due to an RCA or a circumflex. So if you are dealing with a left main lesion, so if the patient has a left main block, the blood supply to the entire left coronary system is gone. That patient will have a massive antral MI or non-ST elevation MI, whatever it may be. When the patient has a block at the left main, you have to give a most guarded prognosis. Likewise, if the patient has a proximal LAD, as I told you, LAD is the most important artery out of these 3. So it is a widow's artery. So if the patient has a proximal LAD block lesion, you have to give a most guarded prognosis to that patient. How do you diagnose that this patient has a left main disease, this patient has a proximal LAD disease? I will tell you in a very simple way. This is a Cariogram message slide. Remember 2 R's when you are dealing with an antral MI, whether it's a non-ST elevation MI or ST elevation MI. AV or ST elevation, then that patient will have a left main lesion. AV or ST elevation, if you notice, then that patient might have a left main lesion. If a patient presents with RBBB with antral MI, that patient can have a proximal LAD lesion. The hallmark of the left main lesion is, as I told you, AV or ST elevation. So if you want to remember one ECG from my presentation, remember this ECG. So this is a classical ST elevation in AVR, you are dealing up with a high risk patient and give the most guarded prognosis at the time of admission in the casualty department itself. Yet another ECG of gross ST depression in anterior leads, but notice the AVR ST elevation, which can be seen in the left main lesion. As I told you, if the patient has a proximal LAD lesion also, that you have to give a guarded prognosis. If a patient has an anterior wall MI with bundle branch, right bundle branch block, give the most guarded prognosis. That patient can have a proximal LAD lesion. So I finished my talk. I'll just take 2 minutes to revise the most important 9 points to be kept in your long-term memory from my presentation. Point number 1, do not forget to compare with the previous ECG when you are dealing up with a patient with chest pain in casualty. Point number 2, in a diabetic patient or patients with multiple coronary risk factors, do not tell the patient attenders that everything is normal, even if the first ECG is normal. Point number 3, do not do troponin T to rule out cardiac cause for chest pain if the onset of pain is less than 6 hours. Point number 4, always admit a patient who comes late in the night with chest pain, even if the character of the chest pain is atypical and even if the ECG is normal, at least give an option of admission. Point number 5, so ST segment starts from the J point to till the beginning of T wave. So to say it as a significant ST segment elevation, it should be more than 1 millimeter in limb leads and more than 2 millimeter in precordial leads, 2 contiguous leads. Point number 6, remember to focus 2 sets of leads when you are dealing up with a patient with ST elevation MI, V1 to V6 and 2-3 AVF inferior leads. So if the patient has ST segment elevation V1 to V6, anterowall MI. If the patient has ST segment elevation in 2-3 AVF, it is inferior wall MI. Point number 7, culprit vessel in an anterowall MI may be left main or LAD. Culprit vessel in an inferior wall MI may be RCA or circumflex. Point number 8, remember to prognosticate and risk stratify at the time point of admission in the casualty department itself. Lastly, point number 9, prognostication of anterowall MI. Remember 2 R's. AVR ST elevation, it is signifying a left main lesion. RBBB with anterowall MI signifying a proximal LAD lesion. Thanks for the patient listening.
Dr. Senthil Kumar, sir.
Yes, sir.
Good morning, sir. Dr. Ganesh.
Good morning.
Thank you very much, sir. Thank you very much for the very detailed presentation from the basics to the maximum clinical application that is possible at the junior doctors level. So we all enjoyed the lecture. I think many of the students here who junior doctors who have all enrolled here would have taken notes. Try to remember the important points. If possible, record the video, because these points are real gems that will not be available in many of your textbooks. Even if you get those points, it will be in between the lines. So I once again tell the students, because we have called for speakers, they are sparing their most time from the busiest schedule. So it is very important for you to utilize this opportunity. Thank you very much, sir. Thank you for the fireworks presentation.
Thank you.
Thank you, sir.
Thank you, Dr. Ganesh, for the opportunity.
Welcome, Dr. Jayapandian, sir. He is our next speaker. So I would like to take this opportunity to welcome him and also thank him very much for sparing his most important time, especially during the weekdays and during the peak hour of the day. Thank you, sir.
Thank you, sir.
Thank you, Ganesh. Can I go ahead, Ganesh?
I think we can go out to the speaker introduction and then we can go to the topic. Dr. Aishwarya is there for the introduction?
Ganesh, can you see my slide?
Yes, sir. Yes, the slides are clearly visible.
Okay.
I welcome our next speaker. Dr. Jayapandian, sir, who has completed his UG from Madurai Medical College and MD General Medicine from Madras Medical College and DND Cardiology from Madras Medical Mission. and he's also undergone the postdoctoral fellowship in electrophysiology and pacemaking under Dr. Narasimhan at Care Hospital, Hyderabad. And Sir is currently working as a senior consultant cardiologist and electrophysiologist at Meenakshi Mission Hospital and Research Center, Madurai. Sir has various publications like radio frequency ablation of deep-seated outflow tract ventricular tachycardia using custom modified bipolar irrigated radio frequency ablation, and he has also been awarded the Dr. J.C. Patel and Dr. B.C. Mehta Award, JAPI Award 2007, and Sir has also presented various posters and cases in the Capricorn, Apicon, and City Physician Club. He has also presented the impact of early diagnosis and cardiac sarcoidosis in an Australian conference. Thank you very much, Sir, and I welcome you to address the gathering on arrhythmias.
Okay, thank you. Thank you, Ganesh. I sincere thanks to my senior and one of the senior most cardiologist in Tamil Nadu, Janardhanan sir. And my sincere thanks to Ganesh and other senior colleagues, my dear students. So today our topic, Ganesh, can you see my slide?
Yes, sir. Yes, sir.
Sir, it is seen.
It's in.
Slides are visible, sir.
Yes.
You can carry on.
Yeah, okay, yeah. So today my topic is related to arrhythmia. So the agenda is tachyarrhythmia and bradyarrhythmia and blocks and particularly fascicular blocks. The given time is 25 to 30 minutes. I try to finish, and before going to that, being our CRRI colleagues and other people are in our audience. So first each and every topic, first few slides for basics and easily understandable, and next one or two slides for our PG students for understanding of arrhythmia and diagnosis. So before entering to the mainstream, I just go to the first tachyarrhythmia. Of this tachyarrhythmia, I will go for supraventricular arrhythmias, easily to diagnose. You can see the ECG when patient come to the emergency with the palpitation, syncope, sometimes sweating, and rarely some patient present with hypertension. So if you are presenting like this ECG, how we have to proceed and treatment of it. Once you reach the patient, these 5 points has to be seen, whether we have to treat immediately or we have to take a good breath and take the ECG analysis and treatment. So if it is patient comes with hemodynamically stable, that first point. If it is not hemodynamically stable, go for DC version, shock it and revert the patient. If hemodynamically stable, then go for next step, find the tachy. What is the tachy it is? It is AV node as a part of circuit for treatment purpose. If it's so, block the node by giving drugs. So which drug to be used and prepare the patient. So before going to that, what are all the AV nodal dependent tachycardia? That is the part and partial of circuit is the AV node one. So that is one AV NRT, AV nodal reentrant tachycardia. You can see here that AV node have, everyone knows that. I'm not going to detail about it. Have a fast and slow pathway. If it present in that one, if there is any refractory changes in the pathway, particularly slow pathway, the patient may develop this tachycardia due to some APCs infrequently developed. Like that, some pathways like a WPW or concealed pathway, that is also like this picture doing that, through the pathway and going down and towards the node, and will produce the tachycardia circuit. Where the circuit also part and partial of node, we have to give the drugs which blocking the AV node, then we will terminate the tachycardia. Now, AV node not dependent tachycardias are atrial tachycardia and flutters and atrial fibrillation. Usually atrial fibrillation, we won't take it into the supraventricular. It's entirely different scenarios we will going to be discussed, and easily to be a diagnosis also. In atrial tachycardia, you can see it is not a reentrant circuit. It is a focal. it focal, either to have a lot of mechanism, particularly most common mechanism is triggered activity. So here in the picture shows there is a one point from where it shower like activities will develop. Like that, atrial flutter, it is also it's a macro reentrant, but it's not dependent on the AV node. It's on the macro reentrant. Cavo isthmoid tricuspid annulus is a junction point from where it can round it. You can see this one. This is a circuit will develop the flutter. So here that AV node, it's not a part of flutter. If you are giving AV node blocking drugs, here nothing going to be happen. The tachycardia will be keep on running. Sometimes a transient AV node block, some QRS may not contact to the ECG. So now come to for proper diagnosis. When you are approach the SVT, we have to see first 3 points. I have a 5 to 6 points to yearly diagnosis. 90% we can reach the diagnosis by this one. So first is one, it's a narrow QRS or not. If it is definitely narrow QRS, then you have to go for, is it regular or irregular? If it is regular, that it is in our part. If it is irregular, then it will go to the atrial fibrillation, multifocal atrial tachycardia, or atrial flutter with varying block, or atrial tachycardia with varying block. So that is not going to be a AV nodal blocking drugs. So we have to give some other drug like a cardrone, amiodarone, like that. So that regular one, then we have to come into that whether is 1-to-1 contaction is there. If it is, there is a 1-to-1 contaction, definitely so there is a AVRT is a rule. AVNRT, there is a possible, I want to tell something here, there is an exception in arrhythmias. Now in today's presentation, don't take the exception as a part. So I am going to 90% whatever in the practical life, so I am going to tell them. So whenever the 1:1 conduction, if it is definitely AVRT, then AVNRT. There is a less likely to a possibility of 2-to-1 conduction in the AVNRT, that's leave it. Now 1-to-1 conduction is there, that I saw the picture, definitely AVNRT and AVRT. Then if you have a 1-to-1 is not there, but it's a regular narrow QRS, you can see 2-to-1 or 3-to-1. If it is atrial rate is high, when compared with the ventricular rate, there is a high possibility of atrial tachycardia or atrial flutter. This is up to in this slide up to this one. How we can see the P wave? Definitely, if you are not appreciating the P wave in this like kind of ECGs, definitely 90% it will be a AVNRT, less likely to be a AVRT. Both can be treated by AV nodal blocking drug like adenosine. If we are visible seeing, that we cannot be ruled out, but still we have to get our diagnosis to be fine-tuned. So the next step we have to go for RP interval. RP interval is nothing but R wave to next P wave. That tachycardia will always running like this, R wave, then followed by P wave in this one. Here, if you are not seeing, I already told, if you are not seeing P wave, it's definitely AVNRT or AVRT, particularly AVNRT. Or if you are assuming, we have to assuming for diagnosis to be precise, you have to assume that which one to be a P wave. So definitely the P wave should be inside the QRS complex. So you can see that definitely P wave should be this area only in this ECG. But here it's very difficult to find out, but it can be here only. So here, which one is the R wave in this ECG? If you are seeing R wave, this one, then P wave it should be there. So if RP interval less than 70 millisecond or 80 millisecond, that means 2 small squares. One small square is a 40 milliequivalents. 2 small squares is a 80 milliequivalents. If it is within the 2 small square, that definitely it's a AVNRT. So or AVRT. AVRT little bit higher, 70 to 80 millisecond. Don't confuse it. We can take it as a 80 millisecond. If 70 to 80 millisecond, like this ECG, so it is a short RP interval, it's a AVNRT or AVRT. AVRT means pathway related or WPW related. If this is in this example, is this a R wave, then if you take it as a P wave, that RP interval is very long. So it's more than 90 milliseconds. It's a point of, it's ruled out to the typical AVNRT and AVRT. That other possibilities, atrial tachycardia, sinus tachycardia, there is a one entity as a atypical AVNRT. This is a basic level. In PG level, there is a one slow conducting pathway like PJRT, persistent junctional reciprocating artery tachycardia. That is also will produce, even though it's a pathway, it will produce a slow conducting, due to slow conducting pathway, it will produce a long arping tachycardia. Before going to that next slide, I will come back. This, what are all the RP interval? That's RP interval. This is a typical AVNRT and AVRT. Long RP tachycardia, what are all the possibility? Atypical AVNRT, atrial tachycardia, sinus tachycardia, PGRT. This is I already told. These atypical AVNRT, AVRT, atypical, typical AVNRT, all are will well respond to adenosine for reverting the tachycardia in your emergency. Now come to other thing. This ECG you can see here, it looks like a narrow QRS, it's like a AVNRT. If you are seeing properly by using this RP interval, and one more point for PGs to come to conclusion as a atrial tachycardia. You can see here is a RP interval here. You can see if you are taking its R, this one, the P should be here. So it definitely more than 2 squares. So it's a long RP tachycardia. So if it is long RP tachycardia, either atrial tachycardia or AVNRT. Now atrial tachycardia, that means you understand this, that atria, it's firing that from one point, it's a very speed, that AV node respond well and good. It's not dependent on the AV node. P wave will fall different places, and it's conducting in the AV node in the different refractive periods, so it will produce a VA wobbling. It conducting with a different refractive period, different timing, so it will produce a different RP interval, that VA interval. This VA interval, this is a V, this is A, or otherwise RP interval. That I am telling in the electrophysiological part as a VA interval. If it is talking in the ECG level, it's a RP interval. So you can see here, I am showing this marker, arrow mark. You see that baseline very carefully. It's keep on changing. So our AVNRT, definitely it won't change. You see that AVNRT? It's keep on regular, no much changes. If you are coming here, it's also look like a AVNRT or AVRT, but we can diagnose by seeing this one. You see this one? This is a atrial tachycardia with regular conduction, 1-to-1 conduction. So another example is long RP tachycardia. We regularly seeing sinus tachycardia. Sinus tachycardia also is one of the long RP tachycardia. The treatment is, what is the cause? You have to treat the cause. It will be thyrotoxicosis or anemia, or sometimes near the SA node will develop like a atrial tachycardia. All are long RP tachycardia. You can treat the cause by longer. Now come to some non-specific clues apart from your diagnosis. We diagnose, still you can get some points. This is for PGs. So if you are getting like this ECG, you already got AVNRT or AVRT. Still you can get whether AVNRT or AVRT. So go to V1. If you are find out any pseudo S or pseudo R. If you are getting pseudo R, here this is a pseudo R. This is R. It's like another one. It's a pseudo R or pseudo S. Here this pseudo S is nothing but P wave. P wave fall on that one. It's mimic like some S, pseudo S, because it fall after the QRS. So if you are getting pseudo S or pseudo R, it's a typical for AVNRT. Can somebody mute? There is a lot of disturbance. Now come to another clue. This is STT changes. If you are seeing some narrow QRS tachycardia like SVTs, you can see some lot of ST depression like ischemic changes, like previously Sendisar showed some NSTEMI changes. You can see here lot of STT changes. If you get a lot of STT changes, unless proved otherwise, it's a tachycardia, it's a ABRT, it's a pathway. It's from the pathway. Why it is getting that STT changes? Myocardium getting activated more than the AVNRT. AVNRT, it's activating near the node only. That regular pathway will contact you to the Nagarkis and Purkinje. That system contact to the QRS. But here, the tachycardia will run through the almost one part of the myocardium, then join to the conduction system. So that STT changes can be due to myocardial involvement of pathway. So here you can see if it is that STT changes, your diagnosis, the treatment is not going to be changed. Same only that adenosine. But you can get once going to CRR level to PG level, then you have to crisp your diagnosis is due to AVNRT. Another clue that if there is a speed, if it is the tachycardia is more than 200, like more than 180, 250, it's more likely to be a AVNRT than AVRT. Now, another clue, if you get like this kind of narrow QRS tachycardia with alternate pattern, it is due to alternate pattern. One QRS is big, one QRS small. That is also one clue for pathway, accessory pathway. This again, that mechanism is myocardial activity with varying refractoriness of myocardial conduction. That gives the electrical alternate. That is also clue for it's a AVRT as your diagnosis. The treatment is node, block the node, it will be. If it is irregular, narrow QRS, if it is irregular, then you have to come to 3 diagnoses as our practically long of the lot of cases when you are seeing 90 to 95% of cases within 3 this one. So remaining 5% leave it. I already told lot of exceptions will be there. Don't bring the exception here. It will confuse it. So atrial fibrillation, atrial tachycardia with the flutter with a varying block, that will be giving the irregular narrow QRS, and multifocal atrial tachycardia, usually the presented with the COPD patient, that MDPG is well known and regularly seeing this. You can see is a flutter wave. When you are seeing this particularly V1, you can see the flutter wave. It's so every flutter wave is a P wave. It conducting the according to the AV nodal conduction capacity, that is refractiveness of AV node, and it will conduct through the myocardium. So these are flutter wave, or otherwise called sawtooth pattern. When in the flutter for PG level, if it is typical flutter, atypical flutter, you can concentrate on the 2-3 AVF. If there is a negative wave of P wave, that sawtooth pattern is a negative one, that is a typical flutter. Typical flutter means that I already told, it depends on the KO isthmo tricuspid annulus. It's a part, if you going through down to up, it's a typical. If up to down, it's a positive flutter wave will be there. It is a atypical flutter. Now come to multifocal atrial tachycardia. Multifocal atrial tachycardia, 3 definite criteria, 3 different morphology of P wave, 3 different PR interval, 3 different RR interval. This is a multifocal. The classical example is COPD patient. You can see here 3 different P wave morphology, 3 different RR interval, 3 different PR interval. So it's typical of multifocal atrial tachycardia. You have to treat with if not contraindicated beta blocker, you can go that, or otherwise if they're contraindicated, you can treat with the amyotroph. Now come to VT. So there is a lot of points in the discuss to SVT. I'm just stop here to just diagnosing the SVT. Now come to wide QRS tachycardia, the otherwise called ventricular tachycardia or ventricular fibrillation. This is a ECG. When patient come with our ER, then you have to see that. So hemodynamically stable or unstable, I already told. That is also fit into the VT. If it is hemodynamically stable, no need to hurry for going for shock. So you have to take a
Wait
good
for
breath
no
and diagnose. Then you have to analyze if you are failing, it is your diagnosis VT, then go for shock or whatever, pharmacological cardioversion, and check that echo, is there any clot, those things and all you can. If hemodynamically unstable, you have to shock it, whatever it kind of VT. So the definition, wide chorus complex tachycardia with rate of more than 100, that is a definition, and QRS more than 120. If all wide QRS tachycardia more than 80 to 90% is a VT, unless proved otherwise. You keep it. This is the point number one. Next is, there is a possibility of 15 to 20% of case with the SVT with aberrancy, SVT with the background of LBBB, SVT with the bystander with antidromic WPW like pathway, these and all. When these kind of 15 to 20%, so patient hemodynamically stable, analyze your ECG, go for treatment. If SVT with aberrancy, if you are thinking very confidently, then you can give the block the node. Then you no need of giving the shock to the patient. That is today our idea. But the VT diagnosis, we have around 9 algorithm. It's all are 100% specific, 80 to 90% only specific. So sensitivity high. So I'm just going to my view to your level and CRRA level for whether VT or SVT with aberrancy. This kind of thing. Next few slides I already told, some few points, give my approach, that is my approach, give that specific diagnosis of VT. So we have to go for, if it is wide QRS, yes, if it is wide QRS tachycardia, then immediately you have to go for axis. Better if you have a old ECG, then compare with the axis is better, or otherwise, some axis will be there, that it should be a VT, that I will come to next slide. Then monomorphic, all V1 to V6, all are in the same direction. It's called monomorphic concordant, whether it's a concordance with all are positive, all are negative. These are 90%, 80 to 90% VT will be there. Some discordant will be there, that don't come into, I already told, again the point is, the exception will be there, don't come into that exception, we will give a few points later. Fourth point is there AV dissociation? If these 4 or 5 points easily diagnosed by your ECG. So AV dissociation present or not. Another important point is capture or fusion beat or present or not. Particularly this capture and fusion beat, 80 to 90, particularly 90% of VT only can be present. Very, very rarely there is a SVT like patient sometimes can present. That is, we won't call it as a AV dissociation, we call it VA dissociation. Wherever that AV dissociation or VA dissociation is there, we can get the fusion and capture beat. And one more important point, this is my analysis when the patient on once seeing the ECG. If you have not seen any RSR pattern in your ECG, that in the top of the V6 or V1, that chest leads, that no RSR pattern, it's a VT. If there is RSR pattern, there is a more likely to be a SVT with the aberrancy. That is a one point, it can fit almost 90% of the patient. That point is RSR pattern, not RR pattern, RSR pattern, only RSR pattern. Now come to some points about ventricular tachycardia, that I already told, with aberrancy of Purkinje system, antegrade conduction, bizarre baseline, that is baseline LBBB, RBBB, or electrolyte ventricular pacing rate, or artifact. Why we have to recognize this VT? That is, I want to give this slide for CRRI for not misdiagnosing as a VT as a SVT. When you are VT as a SVT, when you patient ongoing VT, if you are confidently, some people I told that JPs are told like this one, so I diagnose as SVT. Then giving up verapamil or adenosine, already hemodynamically stable VT will become a hemodynamically unstable VT. Then we will become an emergency, you have to shock it. Because adenosine and verapamil are vasodilators. So already SVT patients are on borderline BPR 110, 160, 110, 60 like that. When you are giving adenosine and verapamil, your BP definitely going down to the hypotension. Then it will become a it will become without termination, and patient go for hypertension, you have to shock it. That's why we have to hemodynamically stable patient, you have a careful VT diagnosis. Yeah, or if you are wrongly labeling as a SVT, sometimes it's terminated like septal VTs, sometimes response to adenosine. It wrongly diagnosis or relabeling as a SVT, that inappropriate chronic therapy will going on, keep on patient coming with the VT and landed with the patient septal VTs. These are landed with the patient with dilated cardiomyopathy, LV dysfunction, tachycardiomyopathy. So these and all we have to rule out by our medical profession is very important to avoid this kind of misdiagnosis. So another important thing, assumptions in our practice, our seniors will killing that. The wide complex tachycardia is an alert, hemodynamically stable, must be VT. So the wide complex tachycardia, patient is alert, there is no hemodynamic instability. It is a SVT, not a VT. It's always wrong. All VTs are hemodynamically stable unless otherwise is that the patient have a comorbidity like ischemic heart disease or other valvular disease. These kind of things are long standing. For example, if 5 hours, 6 hours VT, it will go for slowly hypertension. So that assumption also wrong. Next, the patient with the VT always unstable. That is also wrong. I already explained that. So almost 80% of VT can be if EF is normal. So always stable. Even moderate LV dysfunction, that stable VT will be a hemodynamically stable one. So another important point, why the VT shows wide QRS, that wide and more than 120 occurs when ventricular activation abnormally slow. Particularly, you can see that arrhythmia originate the outside of normal conduction system. That means myocardial origin. Usually what we have SA node, AV node and His-Parkinson system, like that it will. Now there is a dominating rhythm which taken from the myocardium, from there it will activating. So that is myocardial part always conduction slower than the normal conduction system. That's why it's a bizarre and broad QRS according to the site of origin of VT. If it is RBBB, it arising from the left side. If it is LBBB, arising from the left side. Or otherwise, His-Parkinson system have a disease or pre-excited tachycardia. Like already WPW patient developing AFib, all AFib, that point you can keep it. This is very, very important. When WPW, that pathway from antegrade conduction, it's notorious. It can conduct any number of stimulus from the atrium. So very careful that pre-excited tachycardia will become a VF. It can be a life. Don't give adenosine here. So we have to give a shock here. I will show the ECG in next few slides. So the morphology, if LBBB morphology QRS more than 120 millisecond, that diagnosing part, the predominantly negative terminal deflection of V1, that is a 1. We have to precise our diagnosis because of intraventricular conduction type of LBBB will be there. It should not be take it as account. It should be predominantly negative terminal deflection in the V1. I will show that. And RBBB morphology, same thing, the positive terminal deflection in the V1. So when you are patient receiving in the ER, when you are taking history, you can do some maneuvers, except old age people, we have to be careful. The response to the arrhythmia to maneuver, the provide to the insight of mechanism. You have a doubt, hemodynamically stable, patient is a wide QRS tachycardia, slowly talk to the patient, taking some history, then do the carotid sinus massage, enhance the vagal tone. If there is you have a doubt, already you have to see the ECG also, you have a doubt, if vagal tone, if due to supraventricular tachycardia with aberrancy or supraventricular tachycardia with the baseline bundle branch block, vagal tone sometimes will terminate the tachycardia or slow down the tachycardia. Slow down means atrial tachycardia can be slowed down. SVT like AVNRT, AVRT can be terminated, but VT, nothing will happen. So we have to be very careful when you are, it should be very smart. Just asking the patient, just slow carotid massage. Don't do if it is more than 60 years of age. If it is more than 60 years of age, it's most likely to be a VT. That is, I told one ECG pre-excited AFib. You can see it's like a ventricular tachycardia. Definitely, when you are seeing this kind of irregularity, it's not definitely it's VT. VT almost always is a regular one. It's just subtle changes of VT, subtle changes of irregularity will be, which should not be appreciable. So this kind of irregularity, it's always is a AFib. So marked irregularity with RR interval occurs with a atrial fibrillation with aberrant conduction or polymorphic VT. Sometimes if it is going very fast, if for example AFib rate is 600 as per book, our theoretical, if 600 will conduct it through the pathway, it's very unlikely to be patient can be live. So patient will go for live and death. This patient will secured by his AV node. Sometimes it's conducted through the AV node. That's why it's some irregular patient in surviving. This kind of patient, you should shock. You should not give the amiodarone. You should not give the adenosine. If you are giving adenosine, that patient is protected by AV node. Some beats is conducted through the AV node. That's why patient is protected. Now you are blocking the AV node by giving adenosine or beta blocker amiodarone. All 600 beat or 400 beat will conduct through the pathway. Will patient go for VF? That AFib terminate degenerate into the VFib, patient will go for die. Another irregularity, you can see the ventricular fibrillation. If this kind of once one rotating its axis like torsades point, it is a VFib. Now come to that axis, our second point. If it is seeing the wide QRS tachycardia, your most leftward axis, it's a more likely to the BT. Already that first speaker told about axis determination. If it is broad QRS with the most extreme leftward axis, that should be a BT. If shift of R, if you have a baseline ECG, already have a basal ECG, then that basal ECG with VT ECG, if compare with the VT ECG, there is a more than 40 degrees of axis deviation. That definitely it's a VT. From the baseline to VT ECG, more than 40, it's a VT. Apart from this, right superior axis, that is indeterminate axis, that is 100% is a VT. That one, if you at all 2, 3, all 1, 2, 3 AVF, it's showing negative, is an indeterminate axis, it's with wide QRS tachycardia, it's almost always is a VT. Like that, you have a RBBB morphology with left axis deviation, you have a 5 points regarding axis and VT. These five points always suggest for 90% of VT. A patient with RBBB morphology with the left axis, it's always suggest of VT. LBBB morphology with right axis deviation, that is also suggestive of VSC. So just seeing by axis wise, we have 5 points to diagnosis the VT. Then QRS duration wise, we can, but it's not a specific, but still we can take it up when we are seeing the ECG is a easiest point for CRRI. In general, wider QRS is favor for VT. That is more than 140 millisecond. If it is RBB like, if more than 140, it's definitely VT. LBB, if more than 160, definitely it's a VT. These for morphology wise, we can diagnose as a VT. In analysis of several studies, the QRS more than 160 millisecond is a strong predictor of VT. Whatever it is, whatever RBB or LBBB, whatever morphology, if more than 160, it's a VT. So these are small points to accumulate to get your ECG. I already told previously, there is a exemption. You should not get a misguided. So if less than 140 millisecond, there is a few exemptions or 2 examples are there, then I will tell that. That is septal VT or fascicular VT. If it is arising near the conduction system or from the conduction system, that Purkinje system, it will produce a narrow QRS only. That exit point is very narrow to the myocardium. So you can see this is a fascicular VT, is a left posterior fascicular VT. It can see as like a, it's relatively narrow QRS. It's not a wide, it's around 130 to 140 milliseconds only. So that is one, keep it in mind. If you have a doubt like this, you have to see is a SVT or something else. You can see carefully, some capture bits are there. If you are, I will come to next slide. I'm just finding for you. If you are seeing some capture beat in between, then your diagnosis is a VT. So your that exemption is what I told previously, little bit different. So here one clue we can get it. So concordance, that is a very important. That is also giving a more specific points. And concordance present when QRS complex, all 6 precardial V1 to V6 is a monophasic. Same like morphology, either negative or positive, either entirely positive, tall or wave with the entirely negative, deep monophasic QS complex. If any of the other biphasic, that leave it. Don't today, no need to confuse. If it is there, then I have a 3 points for my PGs to how if it is present like this. So these are one. It's a positive concordance. Definitely VT. Don't take a chance. Other you check the QRS, morphology, and axis. Next we will go for capture beat, AB dissociation. These are present with the concordance, with positive or negative. It's the diagnosis are it's a VT. So the point is negative concordance is present. If your patient have a negative concordance, is a strongly is a VT, and the very exception I told that exception for PGs only. Don't just forget it. And positive concordance is indicate for it's also VT, but not as like a strong like a negative concordance. So presence of concordance strongly suggestive of VT. So high specificity for positive concordance compared with the negative concordance is 95%. So negative is more concordance than the positive. So now come to AB dissociation. That is very important. By eyeballing itself, we can find it out by AB dissociation. AB dissociation is nothing but the VT is running from the ventricle. Atrium sometimes sinus the same time is sinus node also will firing. So the both will be recorded by ECG by 12 lead ECG. So we can get somewhere else P wave and QRS which is not related to both. So that is a one AB dissociation. AB dissociation is characterized by atrial activity that is independent of ventricular activity. So usually atrial rate slower than the ventricular. You know the VT usually more than 150 or 120. That by reference wise 120. So our atrial rate should not be like that. So atrial rate lower than the ventricular rate. So you can see here that this is a V, this is a V. That arrow marks are shows P wave. So there is no association at all. This is called AB dissociation. Another important point I will give you, when you are seeing the baseline, it will be keep on distorting something. You see that P wave come and distorting their baseline. You have to see the lead 2 always. Take a lead 2. You have a doubt of AB dissociation. I have some doubt if that speed is high, the tachycardia rate is high, there is some doubt will be that a very difficulty to diagnose. So if you are seeing that, you can see here some distortion of baseline, then you have to come to conclusion of AB dissociation is there. So just this is a one complete AB dissociation. This cartoon just for your understanding, I just put these are P wave running its their own rate and QRS is running their own rate. This is a AB dissociation that also 90 to 90% of patients in the VT should have a AB dissociation. Now come to another important point, easily diagnosis, fusion beat and capture beat. First of all, that PGs, leave the CRRI, PGs should know what is the fusion beat. The fusion beat is produced by ventricular activation wavefront characterized by QRS morphology. Intermediate bit, I will explain to that. Fusion beat nothing but when that sometimes that sinus node beat, our beat will conduct through the AV node. At the same time, it will conduct from the ventricle. At some point of time, one myocardium can capture the both beat, will looks like a normal beat, bit higher than because of sinus node also firing. Meanwhile, it's not all beat, it's in between. That is a very important. The fusion beat. Fusion beat means sinus beat, our VT beat. It will fuse like here that VT is running, mean between sinus beat and our VT beat is captured, and this is a sinus beat. It's terminate and again started VT. You can see that it is intermediary between the, just for example, I put up one of my ECG just for your understanding. This is a sinus beat PQRS and this is a VT beat. It is a intermediary between these two beats. So this is a fusion beat. Capture beat, I already told one ECG that fascicular VT, that capture beat or stressor beat, otherwise nothing but the QRS complex during ventricular tachycardia. Even though running ventricular tachycardia at that time, it can solely its own sinus beat can come into that in between that. There is a possibility. That is a capture beat. So in between that own sinus beat will come and capture the particular myocardium, will produce the capture beat. Capture beat almost it's look like a our sinus beat or little bit narrower. So the fusion and capture beat more commonly seen the VT with a slower. If it is faster VT, we could not appreciate. It will be there, but could not appreciate by 12 lead ECG. So these are basic for when you are seeing the 12 lead ECG. We have a lot of algorithms are there. PGs can read it, Valence, Brugada, and modified Brugada, Griffith, Bayesian, AVR algorithm, and RBW2 and combined. These are algorithms. If there is a, in the books, you can go and read it. And of this Brugada criteria, it's particularly for ruling out the SVT. You can go and read it. Almost we discussed here, last point only. I'm not discussing here. Just to go and see, that is easiest one. And my favorite simple criteria, still all five or 6 points I got it. Then I want to go for simple criteria by without poking my head, and we'll take a 3 points and this is for ECG. And we can get 90%. I am not telling 100%, 95%. Still, there is no 100% specific for VT diagnosis. One more is AVR algorithm. That is very, very important. Take a AVR lead and to see these 4 points are present. That is go for, it's a VT. It's a 90 to 95% specific. AVR algorithm is a 95 to 98% specific point. So is there initial R wave? It's very simple. Is that AVR shows positive or not? Sir, usually AVR won't show positive. If VT beat running, AVR positive, that is also favor for your diagnosis. Is there Q or R wave in the your complex? You can see Q wave or R wave. If it is Q wave or R wave is present, if it is more than 40 milliseconds, that is small square, one small square, that is another point for your VT. These and all simple thing, keep it in mind. And second important is obviously your eyeballing only. Is there notching in the descending limb of negative QRS complex? That's definitely it will for VT. Another is the V initiation and V terminal differentiated by less than 1. This is for what? When patient have a biphasic, I already told monophasic and concordance is a biphasic. Then you can apply this formula PGs. Very simple one. How we can find it out, that one? You can see this is ascending limb, descending limb. Take how much is the duration of this. You just measure how many small squares are there. You just divide it. If it is less than 1, it's a VT. Very simple. This 1 point enough for diagnosing your VT in the AVR criteria. Another important and simple clue, RS ratio in the V6, in particularly RBBBVT. I have common one idea I told AVR for PGs and RBBBVT 1 point, LBBBVT 1 point. If you have a RBBBVT, RS ratio, you have to see the V6. If RS ratio in the RBBBVT less than 1, you keep it in mind, always less than 1 in the VT. Okay, so not a more than 1. If it is more than 1, your diagnosis will be is a SVT. So that specificity also and positive predictive value 0.9. So already you applied 6 points and RBBB morphology. If applied AVR criteria and this one RS rule by RS ratio in the V6, then you have to come to conclusion. Now LBBB type of VT, then you have to see just is there notching in the descending limb. If you are seeing that notching in the descending limb, it's VT. Nothing going to be worried. It's otherwise called Josephson sign. It's otherwise called, is one of the sign is Josephson sign. In one more point is there, you have to see the descending limb origin of point of origin to peak of origin of descending limb for more than 3 small square, that is 100 milliseconds. That is also specific point for VT. So I already put here. You see that these 2 points for LBBBVT, already told for RBBBT and common for ABR algorithm. These 3 is enough. I already told 1 point RSR pattern. If it is present in the RSR pattern, you always, that is, it should be in the peak. It should not be like this. It should not be like this. It should not be previous one. So if it is present, it's always, you have to always think of SVT with the aberrancy. So these and all our point I am telling about, these and all myocardial VT. When idiopathic ventricular tachycardia like septal RVOTVT and LVOTVT, these are a few points you have to keep it in mind that easily diagnosed, no need to go for this idiopathic VT house should not doesn't have this slurring those and all. It should be a stride. So because of it is doesn't have most of the time it's a normal heart. So it won't distort the myocardium. So this is a fascicular VT. For if you have a narrow QRS, like relatively narrow QRS, RBBB, left axis, you unless proved otherwise, you have to think of fascicular VT. So little bit faster than the our VT. These and all by experience. Still you have a doubt, go for AVR criteria. Okay, just go for AVR criteria. It will feel positive for R wave, and you can see the capture beat and fusion beat in between. That there is, it is a fusion beat, it is a capture beat. So it's what is that difficulty in diagnosing this one? It's a fascicular VT, but that narrow QRS tachycardia, it's a relatively narrow QRS tachycardia. Like that, if you have like this kind of VT, if you are seeing 2-3 AVF positive, V1 whether RBBB or LBBB, if we are clearly sharp, decent or ascending limb, if you have always outflow tract VT. This one you have to keep it in mind. You always see 2-3 AVF. If it is positive, it's an outflow tract VT. This is also the treatment part is very easy, and the prognosis also good by giving RFA. And most important and misdiagnosing you is one SVT, it will become, it's most of the time diagnosing as a VT and giving a shock. This is a one, it's not a VT, and you can see the ABR is not giving criteria. This kind of one is a own specific point. Patient with LBBB morphology, relatively wide QRS tachycardia, left axis, transition at V5, V6. If you are seeing like a transition like V5, V6, it's a mayhem tachycardia. It's one of the pathway, it's aberrant pathway. It's like, it's a SVT, it's not a VT. So we have to be careful about this exceptional VT, like fascicular, septal, and mayhem tachycardia. This one, you always keep it in the mind with some specific points. So now coming to that bradyarrhythmia, I will finish, give a time, it may take time. So mechanism, we have a degrees automaticity, conduction clock, and escape rhythm. So there is a 3 ways in the SA node disease or AV node disease. If it is inappropriate sinus brachycardia or sinoatrial exit block, sinus frost, and sinus arrest, and bradyarrhythmia, tachybrady syndrome. Inappropriate sinus bradycardia, most of the athletes have an inappropriate sinus bradycardia will be there. So chronotropic incompetence will be there. Or athletes, our farmers, young workers, and all laborers will have this kind of inappropriate. If that should be a physiology. Whether we have to see pathology one, then you have to think of 6 sinus syndrome. That's for we have to apply this formula for 220 minus age. If you are not achieving that, 80%, if you are not getting that, you have to go for I will little bit rush it out because of next few slides are important. So sinoatrial exit block, we use most of the time, our people will diagnosing as a blocked APC or APC with incomplete compensatory pass. It's not like that most of the time. You have to carefully seeing that sinus exit block, sinoatrial SA exit block, it can be easily to be find out. So sinus node discharge the impulse, but does not result the atrial. It will be in the node only. It won't exit from the node. So we could not find out from the exact point the ECG. So 12 lead ECG we could not very difficult to find out. So we can find out only second degree XA exit block. First degree XA exit block very difficult. We can find out only by EP study. Second degree only we can find out by ECG. That's why I'm going to be showing the next few slides. Third degree, there is no P wave, so it will be a sinus pass. It's a long pass only. It's easy to diagnose. So the I already told is a type 1 is a Mobitz type 1 and Mobitz type 2 only we are going to see. So progressive prolongation in the SA node conduction, intermittent failure or regular failure. That's one we are going to see. So normally if people are seeing this one, so the people are thinking of sinus bradycardia or some APC common incomplete pass or blocked APC, they will tell. It's not like that. If you are applying this rule, it will be a sinus SA exit block. If you have to always measure your PP interval. This is PP interval. When SA exit block, I already told that the prolongation means shortening up that refractoriness, that prolonging shortening of PP interval, then dropping. That missing out P wave. It's a SC exit block. Give up 1 minute, seeing that rhythm strip V1 or lead 2, seeing the PP, take a pen and mark it PP interval. If prolong progressively shortening PP interval, dropping P, it's a SA exit block as a type 1 Mobitz type 1 only. So this is an example here. Here the PR interval, PP interval shortened prior to the block. Like that, Mobitz type 2, we have no change in SA node conduction, but it's a little bit progressed disease in the SA node. It can present like this, that one P wave abruptly stops on the time. That also you have to see the PP interval. So PP interval is a constant, suddenly dropped. So we usually thinking of is a blocked APC. It's not like that. If you have a doubt, you have to see that the dropped PP interval, it's a doubling of normal PP interval. You can see here, this patient is double the numbers of the normal PP interval. So it's a Mobitz type 2. Just for PGs and TMPGs for this, not for CRRIs. So it can easily find out if it is present like suddenly is a little bit faster rate, suddenly it's become brady. So we are thinking that sinus arrhythmia or some vagatone, those things. It's not like that. It's a SA exit block. It's an example. If it is progressively going on disease, there is no P wave conduction from SA node, is sinus pass. It will exit like a sinus pass. There is no P wave at all. If it is AV node is strong or this bundle is strong, it will take immediately. If it is disease, it will take time to come. The point is here, whatever that your diagnosis, you have to see the P wave morphology. The P wave morphology never change in the SA exit. You have a doubt of APC with atrial premature complex with a block, or APC with incomplete block, incomplete compensatory pass, there is a P wave morphology will be keep on changing, some subtle change. But here, SA exit block, any point of time, the P wave morphology won't be changed. I will show some examples here. This is tachybrady syndrome. You can see the P wave morphology won't change. Here also another example, no P wave tachycardia, bradycardia, then going for sinus pass with escape rate. That is also. This, if this is progression, then it will go for junctional escape like that. Now come to AV block, final one. It's a AV nodal disease. This is for just CRRA, have a AV nodal supplied by AV nodal branch and septal perforator of the LAD and AV node from the LCX and RCA. And it can have a sympathetic and parasympathetic nerve, and his and lower down have a minimal autonomic activity. So here also first degree and second degree, third degree, and again Mobitz type 1 and type 2. So first degree AV block, everybody knows the PR interval prolongation more than 200 milliseconds, constantly present. You can see the example is more than 250 milliseconds here. It's a first degree AV block. Usually, if more than 200 milliseconds, you better avoid blocker or beta blocker and observe it. It's nothing going to be happen, or sometime to be a physiological one. Now come to second degree AV block. Second degree AV block have a two types, type 1 and type 2. Mobitz type 1. Mobitz type 1, you know that progressively prolonging and dropping the QRS complex. Where SA exit block, progressively prolonging, dropping the P wave. Here, progressively prolonging PR interval, dropping the QRS. So you can see the differentiation. PR interval, prolongation, and P wave is there is no QRS. Here, it's not P wave, not conducting to the QRS complex. This is a Mobitz type 1 type of type 2 AV block. So second degree Mobitz type 1, sorry. So the constant PR interval, like that only, it can trap anywhere with a fixed 3:1, 4:1, like it won't follow the prolongation. It drop randomly, or sometimes 2:1, 3:1 way it can. It's 2:1, you can see here. It can block the 2:1, 2:1. Here is one. Like that here 3:1, 2:1, various combination of blocks is there. Here there is no PR interval correlation. It can prevent, it can block. The only point before blocking, the PR interval will be short. That I don't want to confuse. For PG's point, before dropping, that PR interval will be short here. Before block, this block before one, its a PR interval will be short. So another word you keep on hearing in your practice, high grade AV block. What is that one? There is a two criteria is there. At least two consecutive non-conducted P wave, 3:1 or 4:1, like that. That is called high grade AV block. Also called advanced second degree AV block. Or the patient have a wide QRS. So that escape QRS will be a wide QRS, not like a narrow QRS. If it is a wide QRS, that is also high grade AV block, like this. If there is a 2:1 and 3:1, but it have a QRS is a broad one, either ARBBB or LBBB morphology, that is also high. These both are high grade AV block. Definitely patient need a pacemaker. There is no second thought here. So third degree AV block is nothing but there is no correlation between, conduction between atrium and ventricle. There is no relation between the atrial activity and ventricular activity. This is a one. So it can be escape rhythm or ventricular escape. If it is node is healthy, it will taken from the junction. Node also diseased or electrolyte imbalance, so ventricular rhythm. If always ventricular rhythm taken, it's unstable. Patient crash anytime, so you have to go for temporary one. So you can see here that red line I put is a SA node to atrium to ventricle. There is no activity at all. It act different way. This act different way. So you can see here that P wave its own way, and QRS it's going one way. There is no relation at all. The last slide one, fascicular block. When you have a three bundles are blocked, or one bundle with one conduction system block, it you have a fascicular block or trifascicular block. It's otherwise called complete heart block. You can see here RBBB and PR interval prolongation and left axis. Left axis means left fascicular block. Left fascicular block and AV nodal block and bundle branch, right bundle branch. Trifascicular block. Three blocks are there. So it's otherwise called complete heart block. These patients are notorious patient and dangerous patient. In this patient, anytime can go for long sinus pass and is life for dangerous. Compare with a stable complete heart block. Thank you.
Thank you, Dr. Jayapandian sir, for the detailed presentation. Arrhythmia, we all know that it's a very vast topic and a complicated topic.
Yeah.
So that's why we wanted to invite a electrophysiologist to talk upon this. You made justice to this topic as much as possible to cover in this short period of time. I think most of our young doctors would have benefited from this wonderful lecture. Thank you very much for sparing your precious time for giving us, and thank you, sir.
Thank you, Manish. Thank you for giving me the opportunity.
I welcome our
1 minute. Jayapandi, hand of
Sir,
Janardhan.
good morning, sir.
Jayapandi, you have done a wonderful job in your busy schedule. You have given a slot for us and you have helped for our college. Thanks a lot for wonderful presentation. Wonderful presentation. Thank you.
Thank you, sir. Thank you very much. Thank you, Ganesh.
Thank you, sir.
I invite our next speaker, Dr. Ganesh sir, who's done his UG from PSG Medical College, PG from Baroda Medical College, and DM in Cardiology from JJ Grant Medical College. And he has also been awarded the gold medal, and he was a university topper in the examination conducted by the Maharashtra University of Health Sciences. And he has persuaded 1 year high training in interventional cardiology at Sir JJ Grant Hospital in Mumbai. And he has more than 10 years of experience in the field of adult and pediatric interventional cardiology. Sir, I now request you to address the gathering on ECG changes in chamber enlargement and bundle branch blocks.
Thank you very much for the nice introduction. Is my slide visible, sir?
Sir,
Is the slide visible?
visible.
And am I audible, sir?
Yes, sir, audible. Very good.
Thank you, sir. Thank you. So we have been covering one topic by another from the morning in this beautiful ECG workshop. We started from basics. We entered into ischemic heart disease and we tried to know what is ST elevation, what are the various types of MI, and then we entered into arrhythmia, which is a very complicated topic which Dr. Jayapandian has simplified as much as possible and narrated in a very beautiful way. And we move on to more lighter topics now. The two more topics that are pending are one is chamber enlargement bundle branch block by me and Dr. Professor Janardhan sir is going to give you a topic on lecture on miscellaneous ECG findings. These two are going to be very lighter ones, so that you can take a breathe and then try to understand as much as possible. So moving on to the topic, first thing I am going to talk upon is bundle branch block. So I am going to talk upon right bundle branch block, left bundle branch block, hemi blocks, that is the fascicular blocks. So we all know that there is a beautiful trifascicular highway in the conduction system. So conduction starts from the SA node, enters the AV node, from there via the his bundle, the bundle branch divides into two, right bundle branch and the left bundle branch. We have discussed already in the first lecture. So the left bundle branch divides into left anterior fascicle and the left posterior fascicle. So this is how our conduction system works. So if we take a patient with who is having a right bundle branch block, so it is very easy to diagnose. I am going to tell only the practical points. I am not going more into the theoretical details because everything cannot be taught in a small span of time. So whatever points that can be taken home and remembered, and it's the most important thing is practically how do you diagnose each and every condition, that is more important. So if you see this is a 12 lead ECG. So to diagnose right bundle branch block, we have to see whether what is the axis. There should not be any gross left axis. The axis should be towards either neutral or towards the right. So we have to focus on two leads. One is the first focus on lead V1 and focus on lead 2, 3 and V6. So the most important lead in diagnosing the right bundle branch block is focusing on the lead V1. So lead V1 shows in the QRS complex, it will be a wide QRS complex. So if it is a complete right bundle branch block, the QRS duration is more than 120 seconds. It can be more than 140 milliseconds also. So if it is, if you see in V1, so there will be a RSR pattern, meaning the first R is small, the second there is a small S, then followed by a large R. So we call it as a rabbit ear sign or a RSR dash pattern, and there is a concordant oppositely directed T wave, that is a T wave will be in the opposite direction to the QRS. So there are three phases of conduction which will reflect on the ECG in case of RBBB. first step is normally there will be a septal depolarization normal from left to right. That will happen. That will give rise to small r, that is the first r in the V1, corresponding small septal q, that is q, small q in the V6. So this will happen normally as like that of a normal heart. So what happens? Then the normal conduction towards the left side is going to happen. That is the left ventricular depolarization. That produces a prominent R in the V6 and a prominent S in the V1 lead. So what happens, since there is a bundle branch block in the right side, so there is delayed stimulation of the right ventricle, as you see here. So this delayed stimulation prolongs the QRS. So the prolonged depolarization will lead to a prominent R wave, which is more prominent than the first R wave, so producing a RSR pattern in the V1. So similarly, there will be a delayed S nadir in the V6. So typical bundle branch block, if you see, septal depolarization normally produces a small R wave in the V1 and a corresponding small septal Q wave in V6. This is a normal. So to start with, everything will be normal. So depolarization of LV will also be normal. But when, since there is a right bundle branch block, this conduction towards the right side will not happen. So it produces a wide R wave in V1 and a wide S wave in the V6. So if you see a RBBB ECG, you can have a RSR dash pattern, or sometimes you can have a prominent and wide QRS in the V1 lead and a wide QRS pattern with a deep, broad, wide S wave in the V6. There are multiple variations in the RBBB, but the classical variation that I have shown is the, for CRRIs to remember, is the RSR dash or the rabbit ear pattern in the lead V1. So this is right bundle branch block. So you have to focus on the QRS and then come to the T wave segment, that is the ST segment, T wave. So if we see T waves, there are some changes in the T wave which will help us to further diagnose the right bundle branch block. So T wave inversions is the right side cyst are a characteristic finding in a RBBB. These inversions are referred to as secondary changes because they reflect just the delay in the ventricular stimulation. By contrast, T wave inversions in V5, V6 are called primary T wave abnormalities. We go back to this ECG. So these are the secondary T wave abnormalities on the right side at leads. That is 2, 3 and AVF if we concentrate. These are all secondary T wave abnormalities. On the left side leads V4, V5 and V6, there will be biphasic T or T wave inversions. These are called primary T wave abnormalities. These T wave inversions are usually associated with RBBB. So we must know what is complete and incomplete RBBB. Similarly, we have complete and incomplete left bundle branch block also. So it entirely depends on the width of the QRS complex. Complete RBBB is defined by a QRS that is more than 120 milliseconds or 0.12 second or more, with a RSR dash RSR pattern lead V1 and a QRS pattern in lead V6. So incomplete RBBB is nothing but the same pattern seen in V1 and V6, but its duration is between 0.1 to 0.12, that is 100 milliseconds to 120 milliseconds. So this is the only difference. So next we move on to the left bundle branch block. Left bundle branch block is, we have seen so many LBBBs since morning, so it is easy to diagnose, similar to RBBB. The only thing we have to focus is in the lead V1 and lead V6. If you see a lead V1 and V6, we can have a spike pattern, or what we call as a M pattern in the V6 and 1. This is a straightforward LVBB where the patient is having a M pattern and prolonged QRS. The QRS duration, if you see, it is between 120 to 140 milliseconds. And if you see in V lead V1, you have a absent R, there is no R wave, only a deep and wide prolonged S wave. So with LBBB, the septal depolarization, the mechanism is just opposite to the RBBB. The septum depolarization occurs from right to left instead of left to right. So therefore, the ECG loses the normal septal R wave in the lead 1 that is physiologically present, and the normal septal Q wave that is physiological Q wave in lead V6. So this should disappear once we have to diagnose the left bundle branch block. So the left ventricular depolarization is prolonged, yielding to a wide QRS. So lead V6, if you see a wide entirely positive R wave, in the lead V1 you see a entirely wide negative S wave. So in the right sided chest leads, that is V1, you see a negative QS complex. The physiology is, the mechanism is same. So since there is a left bundle branch block, so there will be a loss of initial physiological R wave in V1 and septal Q wave in V6. So the delayed depolarization produces a wide QS, sometimes a prominent RS in V1 and wide R in left chest leads. So this is showing a wide QRS with a prominent R, only R, and the absence of Q waves in the V6 and the absence of R wave, the small R wave, physiological R wave in the lead V1. So to summarize RBBB and LBBB, how do you differentiate between RBBB and LBBB? So normally we have in V1, and just to focus on V1 and V6, normally we have a septal Q, small R wave followed by a S wave and then a small R wave in a V1. So this is normal. In V6, if you see, there is a physiological small Q wave followed by a big R wave. No or small, either it's S wave is absent or it can be minimal in V6. So this is the normal pattern. In RBB, what happens? There will be a small first positive deflection, that is small r, followed by a wide S wave and then a prominent R wave. So we can call it as capital R, or sometimes we call it as R prime or R dash. So the secondary T wave abnormalities, that is you see the T wave will be in the opposite direction to that of the QRS. So in lead V6, if you see, there will be a small septal Q, then followed by a wide QRS and a small delayed S wave. So this S wave will be prolonged, usually more than 40 milliseconds, and the T wave will be normal in V6. So LBBB, as I told, the most important thing to remember is this M pattern, wide QRS more than 120 to 140 milliseconds, and if you see in V6, the T wave will be in the opposite direction of the QRS deflection. So LBBB and RBBB are very easy to diagnose. There are multiple causes. I am not going into what are the causes of LBBB and RBBB. The important thing that you should remember is LBBB can be associated with the acute myocardial infarction. That Dr. Sendil Kumar has very well narrated in his lecture. What are the points in favoring the patients with LBBB, whether it is a normal or degenerative LBBB or it is related to a atrial myocardial infarction. So that you must know. Next, coming to the fascicular blocks, that is left anterior. We have two fascicles in the left side, left anterior fascicle and the left posterior fascicle. So the RBBB is a single pathway consisting of just one main fascicle. In contrast, left middle branch as a anterior and posterior fascicle. So how do we diagnose in ECG? So hemiblock, unlike a full LBBB or a RBBB, as the terminology itself says, it does not widen the QRS complex. The QRS complex will be between 90 to 110 milliseconds. It will be not wide as in LBBB or RBBB. So the main effect is a change in the QRS axis. This is the most important point in diagnosing a left anterior hemiblock or a left posterior hemiblock. So the change in QRS axis is must in diagnosing these two conditions. So left anterior fascicular block, if you see, there will be marked left axis deviation, that is more than minus 30 degree or more. In left posterior fascicular block, it produces a marked right axis deviation, that is more than 120 degrees or more. So left axis deviation usually between minus 45 to minus 90 degrees, a QR complex in the lead 1 AVL, a small r, big S complex in lead 2, 3 AVF, and a prolonged R wave at peak time only in AVL, that is more than 45 seconds. These four, if they are fitting in, so most probably we are dealing with a left anterior hemiblock. So left anterior fascicular block. So this is to show what is left and right axis. If you see that These are the left-sided leads, one AVL and two wave is in the positive quadrant. These inferior things are in the right side. If the axis is pointing towards plus 60, plus 90 and plus 120, so mostly we are dealing with a right axis. If we are crossing minus 30 to minus 90, we are dealing with a left axis. The normal axis is between minus 30 to plus 60. So this is normal. So this is a classical ECG representing a left anterior hemiblock. This is very commonly seen even in a normal individuals. As the age crosses more than 40 or 45, the bundle branch can degenerate or fibrose. So in LAHB can be a normal finding. It can be seen in many congenital heart diseases and patients who are having a chronic ischemic heart disease. So the most important thing is how to diagnose. So as I said, small q, prominent R in lead 1 and AVL. And the AVL, if you see, the peak of R is more than 45 millisecond. And the most important thing is prominent left axis. If you see here, the 1 and AVL are positive and lead 2 and 3 are deeply negative. That means the axis is more than minus 40 or 45 degrees. So if these three are present and if the QRS is not wide, it is between 100 to, if you see, it will be around 100 to 110 millisecond. So it is not as wide as in LBBB or RBBB. It is not more than 120. So if these criteria are fitting in, mostly we are dealing with a left anterior hemiblock. So to summarize, we should know how to diagnose right bundle branch block, left bundle branch block and left anterior hemiblock. Left posterior fascicular block is very uncommon and it's slightly complicated to diagnose also. So that's why I am not showing in this presentation. So next we move on to the chamber hypertrophy. So the hypertrophy is a condition in which muscular wall of the ventricle or atrium becomes dilated or it becomes thicker than normal. So it can be either a dilatation or enlargement. It occurs as a result of either a volume overload where the chamber dilates to accommodate the increased blood volume. Enlargement is associated with the atria. There is no atrial hypertrophy, it is only enlargement. So P wave is the corresponding electrical activity that is seen on the ECG with respect to atria. So P wave changes used to identify the atrial enlargement. So hypertrophy in the ventricles is reflected in the ECG with respect to the QRS. So QRS complex is going to show some changes with the help of which we are going to diagnose ventricular hypertrophy. So now we all saw in the first presentation what is a normal P wave. The normal P wave is duration is 0.06 to 0.1 second or 60 to 100 millisecond. So the amplitude is between 0.5 to 2.5 millimeter. The first portion of the P wave usually represents the activity from the right atrium. The second portion, this is lead 2. So we usually see the P wave that is best seen in the lead 2. We take lead 2 as the reference for reading the P wave, either the axis or the morphology. So if the first part represents the right atrial activity, the second part represents the terminal portion, that is second part represents the left atrial activity. So depending upon the amplitude and the duration of the P wave, if it is altered, we are going to diagnose whether the right atrium is enlarged or left atrium is enlarged in the ECG. So there are various conditions that can give rise to right atrial or left atrial enlargement. The most common condition that gives rise to right atrial enlargement is chronic pulmonary disease, that is COPD, or a rheumatic heart disease with a severe, moderate to severe pulmonary hypertension. These two conditions can produce a right atrial enlargement. So left atrium to enlarge, there are multiple causes. The most important in our subcontinent is rheumatic heart disease. Rheumatic mitral stenosis or regurgitation produces huge, even giant left atrium, or the conditions like mitral regurgitation, chronic dilated cardiomyopathy can also have a coexistent left atrial enlargement. So there are various causes. We move on to the diagnosis. So right atrial enlargement, if you see, there should be an increase in the amplitude of P wave. That is, the height of the P wave should be more than 2.5 millimeter. In lead 2, 3 and AVF, we usually take lead 2 as the reference. So if we see in lead V1, normally the P wave will be equiphasic. There will be a positive deflection, there will be a negative deflection in the V1, lead V1 with respect to P wave. So if the positive side represents the right atrial activity normally, negative side reflects the left atrial activity. So naturally in the right atrial enlargement, you have a tall P wave in lead 2, 3 and AVF, and lead V1 we have a prominent upright wave in the lead V1. So if it is there, if these two are there, so most probably we are dealing with a right atrial enlargement. So to summarize the right atrial enlargement, there should be a P wave which is more than 2.5 millimeter in height or amplitude in lead V2, so lead 2. P wave we call it as normally pointed P wave or P pulmonale if you diagnose a right atrial enlargement with respect to a COPD or a chronic pulmonary disease. So P wave is more than taller than 1.5 mm in lead V1 as I showed in the slide, more than 1.5 mm positive deflection. So P wave duration should be less than 120. So why is this more important? If the P wave is more than duration is more than 120, most probably we are dealing with a coexistent left atrial. There can left atrial enlargement also, what we call as biatrial enlargement. So for isolated RAE, there should be a increase in amplitude that is more than 2.5 mm. So left atrial enlargement, if you see increased amplitude in the terminal portion, as I said, the second part of the P wave is the representation of left atrial activity. So once the left atrium enlarges, there will be delayed depolarization of the atrium on the left side. So it produces a broad P wave rather than the tall P wave in respect if you see in right atrial enlargement. So left atrial enlargement is very simple to diagnose. If you see a broad P wave in lead 2, 3 or AVF inferior leads, and what happens to the lead V1? As I said, normally it will be a biphasic activity. So second part represents the inferior part represents the left atrial activity. Naturally, this V1, if you see in V1, this second part becomes more deeper and wider, what we call as Morris sign or Morris index. So this duration and the amplitude of P wave on the negative part in V1 is going to increase with respect to if there is a left atrial enlargement. So right atrial enlargement and left atrial enlargement can coexist where there can be both a pointed P wave as well as the P wave duration can be increased. So where we can see in most of the rheumatic conditions what we call it as biatrial enlargement. So coming to the ventricles, ventricular hypertrophy commonly caused by chronic poorly treated long-standing hypertension. So this classically produces a concentric left ventricular hypertrophy. So because there is more muscle to depolarize, there is more electrical activity occurring in the hypertrophied muscle, which is reflected by changes in the amplitude of portions in the QRS complex. So V1 electrode is normally positive in case of left ventricular hypertrophy. Wave of depolarization is moving through LV, moving away from the electrode. So what happens? It produces mainly a small positive R but a more negative deflection, that is S wave, which is more prolonged in the V1. So it produces mainly a negative QRS complex, short R waves with large SAs in V1. So finish the left ventricular hypertrophy and then we come to the right ventricular hypertrophy. So increased R wave amplitude in V6, correspondingly we have a increased R wave activity in the V6. So tall S in V1 and large S wave, large R wave in tall R wave in V6 combined, we can diagnose a left ventricular hypertrophy. So there are various diagnostic criteria to diagnose left ventricular hypertrophy. So we can classify it as a voltage criteria and a anatomical criteria. Voltage criteria is nothing but a Sokolow-Leon criteria is the most important thing, and it is very easy to remember also. So S V1 and R V6, V5 or V6, if we combine, if it is more than 35 millimeter, most probably we are dealing with a left ventricular hypertrophy. Of course, there is one more important criteria called as Cornell criteria. So if you see the S wave in V3 and R wave in AVL, if it is more than 28 millimeter in men and more than 20 millimeter in women, so it is more diagnostic of LVH. So there are other criteria like Framingham criteria and one more important criteria, that is Romheld-Estes scoring system, where Each criteria is given some points you can read. If it read it out, you will not remember. But the most important thing is, if there is more than the points are more than 5, most probably we are dealing with a definite LVH. If the points are more than 4, we are dealing with a probable LVH. The most important thing is mostly things are similar. We should have a deep S wave in V1 and tall R wave in V6. And STT segment is given more importance in this criteria, that is secondary STT changes. So T wave will be in the opposite direction to the QRS complex. If you see lead V6, it will be in the opposite direction that of the QRX. We see V5 and V6, the deep S waves are, T waves are in the opposite direction. So we call it as a asymmetrical T wave inversion in the lead V5 and V6. If you see the V1, S wave is deep, but the T wave is in the opposite direction. The T wave is tall in V1. So these are included in this criteria. With or without digitalis, because digitalis consumption by the patient can produce similar findings, so we add points accordingly. So left atrial involvement, if there is left atrial enlargement associated with LVH, so it increases the specificity of diagnosing the left ventricular hypertrophy. The next point is left axis deviation. The patient is ECG is showing more left axis more than minus 30 degree, so the specificity is more. So QRS duration, if it is more than 90 milliseconds, again we are dealing with a left ventricular hypertrophy. So if I combine all these criteria and get points, secure points, if it is more than 5, most probably we are dealing with a LVH. So if you see this ECG, most of the criteria will be fitting. So there will be a deep S wave in the V1, prominent R wave in the V6. The STT is in the T wave is in the opposite direction in V1 and V6, if you see. And there is a prominent left axis. Here if you see the axis, lead 1 is positive, lead 2, 3 and AVF are negative, AVL is positive. So most probably we are the axis is between minus 45 to minus 60 degree. There is left axis deviation. Left atrial enlargement, if you see the lead 2, there is a wider P than more than normal, so there is some left atrial enlargement. If you see in lead AVL, the R wave is more than 11. So most of these criteria are fitting. So the patient is having a definite LVH if he apply this criteria. So by voltage criteria, if you see, this is the simplest. By eyeballing itself, we can find out. So if you see the right sided lead, that is V1. So if here, if you see the right S wave is around 18 mm, and V5 or V6, if you see the R wave, it is around 23 mm. If you combine, the value is more than 35, so it will be more than 40 here. So it is a definitive LVH. So if we take the AVL alone, this is also very specific. The specificity is around 75 to 80%. So if you have a tall R wave in AVL alone, that is more than 11 mm with the LV strain pattern, that is the T wave in the opposite direction, most probably we are dealing with a LVH. So left ventricular hypertrophy, to summarize, so we have voltage criteria and ST segment changes typically that will be shown. So voltage criteria, S wave in V1 and R wave in V6. I am repeating again, if it is more than 35 mm, it is diagnostic of LVH. R wave in AVL more than 11, it is more specific for diagnosing LVH. R wave in AVL plus S wave in V3, if it is more than 20 or 28, it is diagnostic of LVH respectively in women or men. So ST segment changes typically will show, say, ST segment deviation away from the QRS complex. In V1 and V5, V6, it is definitely suggestive. ST segment deviation is proportional to the size of QRS in that lead. ST segment depression will be concave away from the QRS. This is especially important because we have to differentiate it from ischemia. So your diagnostic accuracy is increasing if you have the following features added on to the voltage criteria. So if you have an associated left atrial enlargement, STT wave changes, wider QRS, slightly prolonged QT interval and a left axis deviation, your probability of reaching the diagnosis of LVH is going to be more, and it is more specific. So coming to the right ventricular hypertrophy, we have specific diagnostic criteria like left ventricular hypertrophy. Here, the most important thing is right axis deviation. As I told, if the axis moves more than plus 60, so more than plus 60, we are having a right axis deviation. So usually in right ventricular hypertrophy, the axis is more than plus 110 degree or more. So if you see in ECG, so there will be a dominant R wave, exactly opposite to the LVH. Dominant R wave in V1 and dominant S wave in V6. If you take the RS ratio, it will be more than 1. And QRS duration, if you see, usually it will be less than 120 millisecond. If there is more than 120 millisecond, usually it can be due to right bundle branch block also. Of course, right ventricular hypertrophy and right bundle branch block can coexist. So typical right ventricular hypertrophy, the QRS duration is less than 120 millisecond. So these are the main criteria: right axis deviation, dominant R in V1 and dominant S in V1 with QRS duration less than 120 millisecond. These are the 4 more important major criteria, but associated supporting criteria are right atrial enlargement if it is there, that is P pulmonale we have discussed, for tall peak, P wave and lead 2, 3 or AVF. If it is present, it is supportive of right ventricular hypertrophy. Right ventricular strain pattern, ST depression or T wave inversion in the right sided precordial leads V1 to V4 and inferior leads 2, 3 AVF. If it is present, it is more supportive. Sometimes there can be S1, S2, S3 pattern, that is for right axis deviation. There will be dominant S waves in lead 2 and 3. All the limb leads, if you see 1, 2 and 3, there will be a S1, S2, S3 pattern. If it is present, this is also suggestive of a right ventricular hypertrophy. So deep S waves in the lateral leads, 1 AVL, if it is present, 1 AVL, V5, V6, if it is present, it is suggestive of supportive of RVH. Right bundle branch block, either complete or incomplete, it can be a supportive evidence for diagnosing a right ventricular hypertrophy. This is a classical example one of a right ventricular hypertrophy. If you see, if you put all the major and minor criteria supportive together, we can almost reach the diagnosis. We will see one by one. So lead V1, as I said, a prominent R wave in lead V1. So see the secondary T wave changes. So it is a deep T wave inversion in the lead V1, typically suggestive of a right ventricular straight pattern. That is most probably we are dealing with a right ventricular pressure overload, which produces a deep T waves like this. So tall R wave in V1 and deep S wave in V6. This is one thing. If you see associated features, there is a right axis deviation. See, 1 and AVL are negative, 2, 3 AVF, these are positive. So the axis is around 100 here, so which is very suggestive. So major criteria, almost all of them are fitting. Of course, there is no prolonged QRS, but the QRS, if it is less than 120, that is also suggestive of a right ventricular hypertrophy, which is very typical. So all the major criteria are fitting here. The only thing is there is a differential diagnosis here. So you should not misdiagnose this as a ischemia. If you see lead V2 and V3, there are symmetrical T wave inversions. This is typical of a right ventricular strain. This is not a right ventricular posterior wall MI, which is a closer differential diagnosis. So ST depression in V2 and V1 extending to V3, if it is coexistent with ST elevation in lead 2, 3 and AVF, this is typically suggestive of a posterior wall MI, but we are not dealing with a posterior wall MI. The other differential diagnosis is a anterior wall ischemia. If you have a coexisting anterior wall ischemia, what happens? These tall R waves will not be present. The R waves will be typically decapitated, or the R waves will be smaller or it may be absent. So we are not dealing with a anterior wall ischemia. So this is a typical ECG of a right ventricular hypertrophy. Coming to example 2, this is a atypical presentation where again, if you see the axis, it is more of neutral or more slightly towards the right axis. So, but you have a right bundle branch block here also. If you see V2 and V1, we can have we see a prolonged QRS. The QRS duration here is more than 120 millisecond. But the supporting evidences are, if you see lead 2 and 3, you have a prominent peaked P wave. The P wave amplitude is more. So right atrial enlargement is there. So tall R in V1 and V2 and if you see the corresponding STT changes, you have a deep T wave inversions in the lead V1 to V2 and V3. So these are the secondary T wave changes supporting the diagnosis of a right ventricular hypertrophy with strain. So sometimes it will not be very typical like this. Atypical features can be there. There comes the use of a supporting criteria like right atrial enlargement, right ventricular strain pattern. Sometimes you can have a right bundle branch block. This is a case where the patient is having acute pulmonary thromboembolism. Patient recovered actually, so the heart rate is normal. So the there is a right ventricular hypertrophy along with a right bundle branch block. So sometimes these can be there. So each and every ECG may not be same. So that's why I showed two examples. To summarize, in hypertrophy, the muscular wall of the ventricle becomes thicker than normal. Dilatation or enlargement of a chamber occurs because of a volume overload where the chamber dilates to accommodate the increased blood volume. Enlargement is associated with the atria while hypertrophy is seen in the ventricles. So the P wave is used to access for atrial enlargement. The QRS complex is examined to identify the ventricular hypertrophy. Indicators of enlargement or hypertrophy include an increase in duration of the waveform, increase in the amplitude of the waveform, and axis deviation. So leads 2 and V1 provide the most necessary information to access the atrial enlargement. So diagnosis of right atrial enlargement is made when there is an increase in amplitude of the first part of the P wave, that is tall P wave more than 2.5 mm duration. So two indicators of left atrial enlargement are: one, increased amplitude in the terminal portion, that is a wide P wave. P wave duration is increased rather than amplitude here. The increased duration or width of the P wave in the lead V1, that is the E wave which is biphasic normally in lead V1 shows a more negative complex. In limb leads, right axis deviation is most commonly diagnostic characteristic of a patient with right ventricular hypertrophy. In precordial leads, right ventricular hypertrophy causes the R waves to be more positive in leads which lie closer to the lead V1, especially lead V1 and V2 represent the septal area, so there will be tall R waves. Left ventricular hypertrophy is identified by increased R wave amplitude in the precordial leads overlying the left ventricular, and S waves that are smaller in the leads overlying the left ventricular, lead V6, but they are larger in the septal leads, that is the lead V1 overlying the right ventricle. So bundle branch block we discussed, it is a disorder that leads to one or both of the bundle branches failing to conduct the impulses. This produces a delay in the depolarization of the ventricular supplies. So in right bundle branch, in bundle branch block, there will be a wide QRS that is usually more than 120 millisecond and a prominent RSR or R prime pattern configuration in the chest leads. So to diagnose RBBB, check for RSR dash pattern in the right sided chest leads, either the leads V1 or V2. So to diagnose LBBB, you look for jump to lead 1 AVL or V5, V6, these are the left sided leads. So you can have a M pattern or a R prime pattern. And to diagnose hemi blocks, the most important diagnostic criteria is axis deviation. Thank you.
Thank you, Ganesh sir, for your excellent presentation of atrial dilatation and ventricular hypertrophy. It's very informative for both postgraduates and undergraduate. Thank you very much. Thank you for organizing such a wonderful meet, sir.
Thank you, sir.
Thank you very much, Ganesh sir. It was a very informative and detailed presentation on bundle branch blocks. And now I welcome our next speaker, Dr. A. Janathanan sir, who has done his undergraduation and post-graduation in MD General Medicine from Madurai Medical College, and his DM Cardiology from Madras Medical College. He was a former HOD of the Department of Cardiology of Madurai Medical College, and he has trained 15 DM cardiology students during his period. And sir is specially trained in MRA and interventional cardiology in USA. Sir also has 28 years of experience in cardiology and 13 years of experience in interventional cardiology. Sir was the General Secretary of Cardiology Society of India during 2013 to 2014. Sir has published 14 papers and he has attended 14 45 national and 51 state conferences. I now invite sir to present the topic ECG in miscellaneous conditions. And a special mention, Dr. A. Janathanan sir is the Professor and HOD of the Department of Cardiology of Dhanlakshmi Srinivasan Medical College and Hospital. Thank you, sir.
இப்படி வந்து குண்டா போட்டீங்க. நீ இருக்கிய கலக்கேரியோட நீ போக மாட்டேங்குது மட்டும் உங்களுக்கு போதா? என்னவா வாங்கினீங்களா இல்லையா? 500 லாட்டு புட்டு பேச்சு மட்டும் பேசுனீங்க. பிடிச்சிருவீங்களே பாஸ். சரியான மிஸ். HLDக்கும் பாட் ஆயிடுச்சா?
சார் எஸ் சார், யூ ஆர் ஆடிபிள் சார்.
ஐடிசி காலியா அதை வச்சுக்க வேண்டியதானே? அப்படியே விடுங்க, வேற எதுவும் இல்லை இப்போ பிரச்சனை. சரி அடிக்கிறதா இவனை கழட்டி விட்டு அடிக்கிறேன். இது மாதிரி இருக்கு பாஸ். அதே மாதிரி வி மாதிரி என்ன பண்ணுவானு?
Okay. Yeah, almost we come to the end of this session, and it was a very beautiful presentation of various papers. So in any meal, there is a main meal, and finally there will be some desserts, and as well as something called pickles. Same thing in ECG. There are very few areas, and which are important in day-to-day practice. It is not a common presentation. A practicing physician must be in a position to make it out. Out of that, the first one I feel is the so-called pericarditis. Because pericarditis is not a common one in day-to-day practice, but it is usually when you come across with acute myocardial infarction, which are a similar ECG picture, which has to be differentiated. Pericarditis is a one condition which is very, very easy to make a diagnosis from clinical point of view as well as from ECG. So, after ECG, you see there is a ST segment elevation well brought out in area. And of course, you can make it out certain things, unusual thing in area. You are able to see a PR segment elevation, and there is a PR segment depression in lead 2. So this is a very classical ECG of a pericarditis. These changes are produced. There is an ST segment elevation is due to a ventricular current of injury associated with epicardial inflammation. Whereas the PR segment changes are due to atrial current of injury, which produces typically a PR segment depression. So if you keep in your mind, you know there is a PR segment which is down below the isoelectric line, you consider the possibility of pericarditis. And always the cavity lead, AVR is always given not much important except in dextrocardia, but in an emergency. It is a segmental approach to the ECG by a treating doctor or a student always see the AVR. The AVR changes sometimes may be very much diagnostic, especially in a case like this, AVR PR segment elevation or sometimes an ST segment elevation, which may give an idea about the left main problems. So diagnosis of pericarditis is very simple. If you are keeping this ECG in your mind in a given patient. And one more thing about the pericarditis ECG is it's a serial evolution. You see the day one, you can see there is an ST segment elevation. And you see the stage 2, the ST segment elevation comes down. And finally, the ST segment becomes more or less isoelectric and see here a beautiful symmetrical T-wave inversion. And finally, it looks more or less near normal ECG. So this type of evolution of the ECG changes, of course, it is not commonly seen in all patients, but it is possible to see at least in few percentage of the patients. To keep it in your mind. In the day-to-day practice, the commonest cause as a cardiologist, we see more and more amount of only ischemic disease. So our number of cases is mostly post-myocardial infarction and pericardial effusion. Whereas in the pediatric patients, it is slightly different. They come across inflammatory etiology. Most common is the viral pericarditis. In between, if you are in a general medicine, you can come across neoplastic etiologies. Of course, in thyroid, here also you can come across, and finally, not the least is autoimmune disorders. Clinical thing is very, very classical. The chest pain in pericarditis is something very short pain, whereas in the case of myocardial infarction, it is totally different. The type of pain is a compressive pain, it radiates. Of course, goes to the jaw, goes to the back, and so the chest pain character is totally different. And ECG is also, I told you, ECG, the ST segment changes are always more or less, it is confined to one segment. If it is RCA, right coronary, it is inferior, left anterior, V1 to V3. This type of segmental presentation will be there in a case of pericarditis. Sorry, in a case of infarction, whereas in pericarditis, it is uniform. All the leads, more or less, there is 2, 3 AVF and V4, V5, V6, and there may not be a reciprocal change, that is ST segment depression in a case of acute myocardial infarction. And when you auscultate, it is very, very easy. A rub, a pericardial rub is very much characteristic. It produces something like when you are using a paper, you hear a noise, or sometimes it is commonly mistaken for a systolic murmur. If you press the step, it becomes more prominent. So it is clinically also very easy. So whatever I have told is there in this small tabular column, that is ST segment elevation is confined to one area, whereas ST segment elevation is confined to widespread. These are the small minor details. Of course, whatever you told in a tabular column form. And in the X-ray will give you an idea. See, this is a cardiomegaly with a pericardial effusion. Very nicely seen. And echocardiogram, you are able to see this is a MOCAT, you are able to see a dark area, what we call it as echolucent. This is diagnostic of pericardial effusion, anterior pericardial effusion. See MOCAT, and this is a 2D echo. You are able to see a posterior pericardial effusion, long axis view. This is a 4-chamber view, and this is of course. Sometimes we do a MRI also. Whenever you are not sure about whether it is a pericardial disease or it is a myocardial disease, called as a restive cardiomyopathy or a pericardial disease, sometimes you may need the help of a MRI, which will give you a beautiful pericardial edema. This very nicely brought up MRI. So the use of MRI is only not a common day-to-day practice, only in a rare occasion we use. So next comes the so-called early repolarization syndrome. This is a very important ECG changes because most commonly seen in our daily practice, especially we come across this population in young patients most of the time. So most of the times are athletes, alarming ECG. So you must know a little bit in detail about the early repolarization syndrome. The early repolarization syndrome, we divide into 4 types. The type 1, the changes are noticed only in the lateral precordial leaf. It is called as more common in athletes. Next one is the type 2, where the changes are noticed in the inferior leaf, that is leaf 2 area, as well as lateral leaves. There is certain amount of risk, I will come to that later. And type 3 is global. ER is globally in inferior lateral and right precordial leaves. The relative risk of some arrhythmia is more high, however, the absolute risk is low. And finally, the Burgras syndrome is sometimes associated with these J-point problems. What is the cause of these ECG changes? It is very simple. If you see the line diagram, on the left-hand side, the action potential in the endocardium and epicardium is more or less same direction. There is a normal epicardial action potential, whereas in the case of ERS, the endocardial potential is normal, whereas the epicardial potential is disproportionately abbreviated. So that produces the ST segment elevation, the J-point elevation. So this is a ECG where you can see the changes. This is called an inferior leaf. J-point is elevated. You are able to see the ST segment elevation in leaf 2 and leaf 3, and of course there are some changes of there in V4, E6 also. This is one another representation. You are able to see the concavity here with the 1 second ST segment elevation, whereas this concavity changes are entirely opposite in the case of ST segment elevation myocardial infarction. Here it's inferior leaf, and you are able to see the lateral leaves also. So, the ECG findings of ERS is a short, well-defined positive deflectionary notch immediately follows of the QRS complex, or sometimes there may be a presence of a slurring at the peak of the terminal part of the QRS complex, or a J-point elevation may be hidden at the terminal part of the QRS complex. And is there a risk? How to risk the early repolarization syndrome patients? This is what I am telling you. There is, at present, there is no risk stratification strategy for the early repolarization cases, because the absolute risk of sudden cardiovascular death is low in the case of early repolarization syndrome. The prevalence of early repolarization syndrome in the general population is around 5 to 13%, whereas in off late, the idiopathic ventricular fibrillation has been associated with some patients of early repolarization syndrome. However, the incidence of the so-called ventricular fibrillation in a population of early repolarization syndrome is very, very minimum. So, in the case of early repolarization syndrome, if you want to consider a case of absolute or otherwise called as arrhythmogenic ventricular fibrillation, it should be associated with history of syncope. There should be some evidence, and you have to rule out other causes. Then only you can say that early repolarization syndrome may be a cause of this ST. So ICD implantation is recommended in patients with a diagnosis of early repolarization syndrome who have survived a cardiac arrest. This is very, very important. You should not give it to each and everybody. And you see this class 3 is not recommended in asymptomatic patient with only a ECG pattern alone. There is no history, just ignore it. Don't make the patient to become panic one. Next one is a very, very important topic, which is, even though it is not common, of late, we see some of the cases of this type of this Burgras syndrome. See, Burgras syndrome is inherited channelopathy of autosomal dominant type, and it is an incomplete penetration and with a variable clinical presentation, which present in the form of a malignant ventricular arrhythmia or a sudden cardiovascular death. The Burgras syndrome has been associated with sodium channel. The loss of function of the sodium channel So the phase 0 action potential of stroke is out,
வந்துடுறீங்களா?
which leads to a heterogeneous loss of action potential with a down pattern and repolarization of abnormalities, mostly between the right ventricular epicardium and endocardium, which makes a very good pathway for malignant arrhythmia. So in this ECG, you are able to see the most commonest form of Brugada's pattern.
சொல்லிட்டு விட்டுருவோம். ஓகே.
The first one is the type 1 of Brugada ECG is mostly seen in V1, V2, V3, a code of ST segment. That is anything in a Brugada, we have got three things. First is J point, then is ST segment, the third one is the T wave. So in the first one you are able to see a code of ST segment, that is more than 2 millimeter. Second thing is J point elevation. A J point elevation is also there. It is also more than 2 millimeter amplitude followed by a negative T wave. This is called as type 1. This is the classical form of Brugada. The type 2 and type 3 ECG patterns they are not that much common. They are not given that much importance also, except in some conditions. The type 2 is here also there is 2 millimeter J point elevation is there and 1 millimeter ST segment elevation is there, but it is called as the saddleback appearance of the ST segment with a T wave. This T wave may be a biphasic or a positive. So these are the criteria what I have told. The J wave amplitude, type 1 is more than 2 millimeter, in type 2 also more than 2 millimeter. Here T wave is negative, here T wave is positive or a biphasic. ST segment, this is a code of form, whereas this is a saddleback form, and ST segment is gradually descending. Finally, there is one entity called type 3. In type 3, here also there is a code of appearance or a saddleback appearance, but ST segment elevation is only less than 1 millimeter and the T wave is fast. You can see this is from this ECG, this is a type 1. You can see the code of ST segment and this is a negative T wave well brought out in V1 and V2. It's a classical type 1 Brugada. This is the approach of any Brugada syndrome. The Brugada syndrome is known for sudden cardiovascular death. So all patients with type 1 type of ECG presentation, if they are symptomatic, the only management is ICD. Whereas a type 1 ECG presentation who are not symptomatic and type 2 or type 3 presentation needs a type of risk stratification whether they need ICD or not. The modality of risk stratification by electrophysiological study is a little bit controversial area, so I am not going to touch. Even after putting the patient on so-called ICD, this is a small diagrammatic presentation of an ICD. So even after putting ICD, some of the patients are more prone for inappropriate shots. The shots are delivered not always the appropriate time. Sometimes the shots may be delivered inappropriately with inappropriate treatment. In such occasion, we add some drugs like quinidine. All this quinidine is sometimes working. So even after using this, if the patient is going for a problem, those patients may need other types of management called as catheter ablation. So with this, we'll come to the another one is hyperkalemic ECG. This hyperkalemia is most common secondary phenomena to renal problem patients. All hyperkalemic patients, you will see a beautiful printing of the T wave. You are able to see the T wave which is printing. This slowly progresses. Because hyperkalemia is in progress, then acts upon the QRS. The QRS becomes widened and the PR interval becomes widened, finally the whole lot, there is no clear-cut PV, QRS, T, everything becomes a sinusoidal waveform. The correlation between the ECG to the serum level of potassium is not always correct, even though some of the textbooks are telling like that, but in our day-to-day practice, there is no correlation. Most of the times, we come across only a peaked T wave. Immediately, we will start the treatment for hypokalemia, the medical line of management. If needed, we will refer the case to the nephrologist for the workup. So next is hypokalemia. The hypokalemia is also a problem of most metabolic problem. Here you are able to see most of the times hypokalemia is the only condition where you are able to see a prominent U wave. So whenever there is a prominent U wave, we think the possibility of hypokalemia. Of course, there is a QT interval prolongation will be there. And hypocalcemia also will be having a longest QT. So whenever QT interval is prolonged, in the absence of drugs, you think of electrolytes is the culprit and try to work out and try to treat the patient. And finally, it's a nice ECG. This is its type of ECG has been given to me during my GM exam. Diagnosis. That's all. It is very easy, that a J point, it looks like something like a splintered QRS, and the J point is elevated. This is called as Ashburn wave, most commonly seen in hypothermia, and of course there is a correlation between the height of the Ashburn wave to the temperature. So this is a very, very important ECG. Keep it in your mind. And of course, this is also a commonest ECG. You will come across in your practice a deep symmetrical T wave inversion, more or less all leads you are able to see deep symmetrical. RRT, something like very deep. This is very classical of hypertrophic cardiomyopathy. Sometimes apical hypertrophic cardiomyopathy will present like this. Finally, this is the final ECG. Why is very, very important? This is the ECG which is commonly reported anteroseptal ischemia. This is the commonest diagnosis given by most of the general practitioners, or sometimes people who doesn't have much exposure to ECG. And sometimes I have seen patients who have been given heparin, etc. So this type of T wave inversion, E1, E2 and E3 is most commonly seen in female. What we call it as juvenile pattern of the ECG. This type of ECG is commonly seen in pediatric population because of the vector. The QRS vectors or direction is posterior, and this posterior persistence may be there in the adult population, which may mimic like anteroseptal ischemia. So always, when you come across this ECG, image alone should not be treated. You have to treat the patient, give importance to the history, and come to a conclusion. And of course, there are some biomarkers are there which will help you. So finally, I want to tell to all students, ECG is one thing, has to be approached in a segmental pattern, not simple rhythm, rate, axis, etc. Chamber hypertrophy. This is a standard approach. Apart from that, if you want to be a very shrewd doctor, you must approach in a segmental way. You see the first waves and lines. See the P wave. See what type of P wave. What is the morphology of the P wave? The P wave, how it should be there in the particular lead, is it there? For example, the P wave should be negative in AVR. Suppose if the AVR is positive, sure, whether it is dextrocardia or a lead inversion. And see the P wave, how, whether it is peak or not. So P wave amplitude growth. From all leads, lead 1 to V6, you assess the morphology, you assess the duration, you will get the diagnosis. Then comes the QRS. Normal morphology of the QRS. Whether it fits with normal morphology, whether the QRS is widened, if this guidance is fitting with bundle branch clot or if it is fitting with intramyocardial conduction clot, that will give an idea. Then go to T wave. What is the T wave? Whether T wave looks like a normal T wave, in the corresponding leads, is it upright or it is inverted, is it okay or it is abnormal? Then you go for a U. Is it there? What is its importance? Is it abnormal? What is its importance? Then you read about the segments. That is PR interval, then once again QT interval. So you each and every case you analyze, you write and make a diagnosis and give it to your teacher. Definitely in future you will become a very good electrocardiogram discussions. Thank you.
Thank you, sir, for your excellent presentation. Even though it is a last speaker, who made the session very interesting, starting from hypoglycemia, and hyperkalemia, pericarditis, and duodenal pattern. These are the places where most of the physician or somebody may commit mistake. Even I have seen one of the case admitted in the very moribund state, and the junior doctor diagnosed it as a infarction. It's a viral fever with myocarditis, and the patient died, the young girl. So, with the experience we are able to pick up, which is whether it's a pericarditis or due to myocardial infarction. It's an excellent presentation, sir. Thank you very much.
Thank you, sir.
Thank you, sir. Dr. Janardhan, sir. Thank you, sir. Very nice presentation. Very nice finish. We call it as Dhoni's finish. Dhoni finishes the match with a six.
Yes, sir.
We finished with a six.
Yeah.
It's true, sir. True.
Thank you, sir. Sir, Shankar Narayan, sir. I take this opportunity to thank everyone. Thank the management of Dhanlakshmi Group of Institutions, Department of Medicine, and our postgraduate students and other faculty members from Department of Medicine and Cardiology who have helped in getting this event successful. I would like to thank the audiovisual team also in helping us to connect and make this event successful. Thank you very much, sir. Following this event, we have a small quiz even for our postgraduates and live ECG workshop also after lunch. Thank you very much, sir.
Thank you, sir.
Thanks a lot, the Professor of another Department of Medicine, sir. Thank you.
Thank you very much, sir.
Actually, it's a very good interaction between the two departments for the benefit of the students. Let us keep this.
Yes, yes, sir.
Thank you.
Thank you, Mr. Thank you. Thanks a lot.
Close.
I would invite Dr. Prakash from Department of Medicine to take over the quiz session and continue.
Okay. So good afternoon to everyone. Now we move on to the quiz competition now. So each quiz carries a 20-second time duration. I keep it here. You can give your answer by analysis in the live chat method in this forum. So we move on to quiz number 1. 55 years a chronic smoker came with complaints of chest pain for past 3 hours. Vitals are stable. ECG showed inferior wall MI. So which one is culprit artery? This was the ECG. Time starts now. So option A is a left main, B LAD, C left circumflex, D right coronary. In this ECG, there is an ST elevation in lead 2, lead 3, AVF, and V5 and V6. The inferior lateral wall MI. Which one is the culprit artery? Live chat answers. Answers, sir. Answers are correct.
Thank you, sir.
Okay, I conclude that the answer is C. Then culprit artery is left circumflex artery. Why? Because of ST elevation of L2 more than L3 indicate left circumflex. The ST elevation of lead 3 more than lead 2 indicate right coronary artery. Here there is an ST elevation of in lead 2 and lead 3 is almost similar. So we move on to the next step. In a right coronary artery, the reciprocal ST depression in lead 1 and AVL. In the left circumflex artery disease, the discordant ST depression in lead 1 and AVL. See, in this ECG, there is a significant STT depression in AVL seen, but there is no significant STT depression in lead 1. Also, there is an ST elevation in V5, V6 to indicate all features suggestive of left circumflex artery involvement. So, move on to the quiz number 2. So, 45 years alcoholic presented with sweating and weakness over the body. What is the prominent features in this ECG?
Sir, prominent you represent hypokalemic periodic paralysis.
Very good, very good. So normally, the answer is D, hypokalemia is the normal correct answer. The normal potassium level is 3.5 to 4.5. This patient have only 2.2, so it's an hypokalemia. So hypokalemia produces a prominent U wave. In this ECG shows a prominent U wave, and there is some QT prolongation and prolonged PR interval. So there is a prominent U wave, there is some QT prolongation and prominent. There is a prolonged PR interval, so to indicate the hypokalemia. Hypokalemia induced U wave is the ECG feature. So move on to quiz number 3. 40 years male, non-diabetic and hypertensive, presented with occasional palpitation. This was the ECG. AVPC only, the malignant VPC, interpolated VPC, and de-interpolated VPC and APC. Anybody? So answer is D, so the interpolated VPD and APD. APD means VPC and APC. This is atrial and ventricular premature beats alternating with the sinus beats. In this ECG, there is a VPC always presented with wide complex QRS with compensatory pass, but here there is no compensatory pass. It is called interpolated VPC. So fifth bit is interpolated VPC, and one more ectopic is there is an atrial premature complex, which one always presented with compensatory pass. So in this ECG, we have the interpolated VPC and atrial premature complex. So both will have the same ECG. So quiz number 4. 65 years hypertensive, presented with chest burning with nausea, vital stable, suprasternal pulsation seen, and auscultation the bilateral basal prebs here. The ECG is A. Antroval B. Unstable angina, C. GERD, D. Malpositions, lead malposition. Anybody?
Lead valve position, sir.
Very good, very good. So the answer is D, sudden loss of R wave in V5. This what happened is normally there is an R wave progression in anterior chest is always increasing in tendency in normal individuals. But here there is an V failure, there is no R wave. V4 had a normal R wave and the V6 had a normal R wave, but V5 had no R wave. Here misplaced V3 lead misplaced in V5 and V5 lead misplaced in V3. So it's a lead misplacement V3 and 2 V5, the lead misplaced here. The small mnemonic to remember that the chest leads, every chest lead have own identity color. If I remember the traffic light, you have the V1 is red, V2 is yellow, V3 is green, and Bob blue. V4 is blue, V5 is orange, and V6 is purple. This is really remember to help to remember the color of the chest leads. Quiz number 5. 12 years old boy, known case of atrial septal defect. In this ECG, inferior leads indicating sign is. This is the ECG. A Wellen sign, B chunks phenomenon, C crotcheted sign, D lead 1 sign. The inferior lead indicating 2, 3 AVF.
Crotcheted sign.
Crotcheted sign. Yes. Answer is C, the crotcheted sign. The knots near the apex of R wave in the inferior leads is seen in ostium secundum AST. See, there is a notch noted in head of the R wave in inferior leads. It's a typical sign of crotchetage, seen in ostium secundum and sinus venosus type of atrial septal defects. So, question number 6. 26 years male, no risk factor, complains of sudden onset of sweating with syncopal attack while driving two-wheeler and came to casualty with excessive sweating. The ECG is?
Audible, sir.
Hello?
You're not audible, sir. Voice breaking.
Brugada syndrome, sir. Option C.
Very good, very good. So answer is C. So Brugada syndrome is a genetic disorder causing sudden cardiac death due to fatal arrhythmia. See, type 1 is code STT elevation. It's a type 1 Brugada syndrome. Type 2 and type 3 is a saddleback type of STT elevation. In our ECG, you see the V1, V2 is a code type of STT elevation. So it's a type 1 Brugada syndrome. Quiz number 7. So ECG shows type 2 Brugada, sinus arrhythmia, complete right bundle, branch block and Wellen syndrome. Anybody pa? So answer is a B, it's a sinus arrhythmia. Sinus arrhythmia is a commonly encountered variation of normal sinus rhythm. Here there is a P followed QRST is there, but varying PP interval and varying RR interval to indicate a sinus arrhythmia. So it's a ECG of sinus arrhythmia. Quiz number 8. 13 years male child, known case of ventricular septal defect. This ECG phenomenon is A. Chunks phenomenon, B. Katzwatschel phenomenon, C. Ashman phenomenon, D. Wenckebach phenomenon.
Ashman phenomenon.
So answer is B is a Katzwatschel phenomenon. It's a tall diphasic QRX complexes. It's an amplitude more than 5 mm in height in the mid pericardial leads V1, V2, V3, V4, typically associated with biventricular hypertrophy. See, in this ECG, V2, V3, V4, there is a diphasic QRS complexes which in height is more than 50 mm indicate biventricular hypertrophy. It's called Katzwatschel phenomenon, seen in many AST patients have it. So quiz number 9. So ECG shows atrial fibrillation, atrial flutter 2:1, Mobitz 1, Mobitz 2. So answer is D, Mobius type 2. So Mobius type 2 is a heart block is characterized by intermittently non-conducted P waves, not preceded by PR prolongation and not followed by PR shortening. There is usually fixed number of non-conducted P waves for every successful conducted QRS complex. Here 2, 3, 4, 5 is a conducted, normal conducted PQRST, but with a slightly elevated PR interval, but not. But there is a fifth P followed QRS not there. So 4:1 Mobius type 2 hot block is there. Quiz number 10. This ECG shows P pulmonale inferior wall ischemia, WPW syndrome. Anybody?
W2W is not.
Very good, very good. His answer is C. This is WPW syndrome. There is a beautiful delta wave seen in the inferior and laterals. It's a segment in between the PR interval. See, it's in a delta wave. It's a WPW syndrome. There is a 5 variant in WPW syndrome. So quiz number 11. 70 years male known case of diabetic hypertension and smoker, complaints of syncopal for 4 episodes since 2 days. ECG shows your answer. Mobius type 2, A Mobius type 2, B complete heart block, C sinus bradycardia, D Mobius type 1.
Complete heart block, sir.
Very good. So answer is complete heart block. The complete heart block is a lack of any apparent relationship between P wave and the QRS complexes. Here there is no relationship in between the P and the QRS complexes. So there is an AV dissociation is there. So based in bradycardia, so it all in conclude this is a complete heart block. Quiz number 12. 55 years male known case of DM with complaints of severe chest pain and sweating since morning. So the ECG, A D ventus, B acute interval MI, C hyperacute T wave in anterior leads, D hyperkalemia.
Yes. David.
Somebody, hello?
Hyperacute T wave invasion with anti-release.
No. No hyperacute T wave.
Hyperkalemia, sir.
No.
Then D ventus.
D Ventus.
The answer is D ventus. The answer is D ventus. It's a tall, prominent, symmetrical T waves in the pericardial leads. There is a tall, symmetrical P wave in the pericardial leads and upsloping ST segment depression more than 1 mm at the J point of the pericardial leads. It's an upsloping STT depression, 0.5. Is a J point.
Excuse me, sir.
Yes.
Excuse me, sir. There is some reciprocal change in 2 on AV of ST depression somewhat. Is anything significant, sir? That's why I have 2 on AV of
No.
ST depression, which is.
No, it's a global T wave inversion, right?
No, I'm asking about ST depression.
ST
2 in AV of,
depression,
sir.
global T wave STT depression is there except the V1 and AVR.
Okay, sir. Okay.
Global T wave inversion. Here there is an upsloping ST segment depression more than 1 mm at the J point. Here the J point, the STT depression is there here. Then precardial leads. I ask if I tell the precardial leads. Okay. Then absence of ST elevation in the precardial leads. Absence of ST elevation in precardial and reciprocal ST segment elevation in 0.5 in AVR. There is almost 1 mm is there in the AVR ST elevation. It's called D ventus phenomenon. It's seen in acute left anterior descending artery occlusion. So it's on D ventus. Quiz number 13. A. Hyperacute MI, first degree AV block. C. Hyperkalemia. D. Wellens. Anybody? So answer is C. It's an hyperkalemia. It's a tented T wave. There is an tall T wave means we can conclude two differential diagnoses. First one is an hyperacute MI. Number two, hyperkalemia. In hyperkalemia, we have the narrow head and base. In hyperacute MI, we have the narrow head and wide base. In hyperacute MI, we have the wide base and narrow head. In hyperkalemia, narrow head and narrow base. It is a help to differentiate hyperkalemia from the hyperacute MI. It's an hyperkalemia ECG. So quiz number 14. 45 years male, severe chest pain radiated to both arm and back. This was the ECG. Your question. A. Pericarditis. B. Inferior MI. C. Extensive anterior MI. D. Atrial infarction.
Pericarditis.
Yes, very good. So the answer is A. Pericarditis is the widespread ST elevation and the PR depression in the inferior leaves, and also the PR elevation in AVR. So it's all suggestive of pericarditis. This is number 15. A complete right bundle branch block with ischemia, left posterior hemiblock, right axis deviation, trifascicular block.
Trifascicular block.
Excellent. The answer is D. Trifascicular block. Here there is a complete right bundle branch block with a left anterior hemiblock and first degree AV block. The three combination is called trifascicular block. If you need bifascicular means right bundle branch block with the left anterior hemiblock is also called bifascicular block. Question 16. 35 years female came with sweating and palpitation, syncope, BP 60 Cori, ECG showed, and also GCS is as low. What is this ECG? How you treat? BP 60 Cori, GCS low.
SVT with DC cardiovascular.
Very well. It's a narrow complex regular tachyarrhythmia. The features suggestive of supraventricular tachycardia. The patient is hemodynamically unstable, so we go to DC cardiovascular. So answer is C. This is number 17. Patient have severe chest pain for past 2 days. A. Brugada, B. Wellens, C. Anterior MI, D. Left ventricular hypertrophy. Brugada syndrome? Yes. Answer very good. So answer D. Wellens syndrome. Wellens syndrome describes a particularly deeply inverted or biphasic T wave in leaves in V2, V3 that highly specific for critical proximal stenosis of left anterior descending coronary artery. See V1, V2, V3 there is an STP biphasic T wave inversion. Biphasic T. It indicates Wellens syndrome. This is number 18. 30 years male complains of dyspnea, chest pain for 6 months and 1 episode of syncope. On auscultation, systolic murmur all over the pericardium. This was the ECG.
Aortic stenosis.
Excellent. So it's an aortic stenosis. The pressure overload induced severe LVH strain in this case. So actually, there is a cardinal symptom of aortic stenosis, dyspnea, chest pain and syncopal attack. There is an ejection systolic murmur all over the pericardium. It's called the Gallaudet phenomenon. In the ECG showed a severe LVH strain pattern. It's a pressure overload, so that's indicate the LVH strain. If suppose patient in AR, there is an upright T wave will appear. So it's an aortic stenosis. Question number 19. A lateral valve MI, B AST, inferior valve MI, dextrocardia. So answer is D, dextrocardia is right axis negative QRS in lead 1 and poor progression of R wave in chest leads. So it's an indicated dextrocardia. Final quiz, question number 20. This P wave indicate Himalayan P wave. Where you get it?
Epstein.
Very good. It's an Epstein anomaly. The answer is A, it's an Epstein anomaly. We have the Himalayan P wave. It indicates more than 5 mm amplitude of P wave. It's seen in Epstein anomaly and tricuspid atresia. Okay. Very well answered. Thank you. Thank you very much. Thank you. Completed. Completed. We conclude the session. Thank you very much. Thank you.
யார் ஃபைனல் இது பண்ணுறது?
அவ்வளோதான் முடிச்சு.
இல்லை ஆஃபீஸ் முடிச்சிருங்க, நீங்கள் முடிச்சிருங்க.
வெயிட் பண்ணுவோம். அவர் சார் ஆல்ரெடி பேசிட்டு எக்ஸிட் பண்ணுறாங்க.
இல்லை அப்படியே தான் வரணும்.
அவங்களே ஆகிட்டாங்களா?
இல்லை யார் இது டைம் சொல்லுங்கள்.
முடிஞ்சா கௌரி சங்கர் சார்லாம் இருந்தாரா?
ஏங்க 18 பேர் தான் இருக்காங்க, 10 பேர் போயிட்டாங்க போட்டுருக்கு.
இப்போ நான் அட்டன் 17 பேர் தான் இருந்தாங்க.
இப்போ இல்லை குறையிறாங்க, முடிச்சுன்னு குறையிறாங்க.
எங்க அந்த பொண்ணு இருந்துச்சு, அது போயிடுச்சா? படிக்க வேறு பொண்ணு. சரி ஓகே, கம்ப்ளீட் பண்ணிடுறேன்.
கம்ப்ளீட் பண்ணிடுறேன். இல்லை கேளுங்க எல்லாம் இருக்கிறாங்க. அதெல்லாம் என்ன பண்ணிட்டு இதை செய்வாங்க. சரி ஸ்ட்ரீமில் கரெக்டாக கனெக்ட் ஆகிருக்குன்னு சொன்னால் க்ரீன் கலரில் வரணும். யூடியூப்பில் போனோம்னா எனக்கு இருக்காது. 500 பேர் தான் இருக்காங்க. அவ்வளோதானா முடிஞ்சு தான் கொடுத்துட்டு ஸ்டாப் கரெக்டாக இருக்கும் ஸ்டாப் கொடுத்துடலாமா? ம் 2 லெவல் கொடுத்துடலாமா? கொடுத்தானா யாருமே எதுவும் கேட்டு இருந்தால் எல்லாருமே இருந்தால் சார் பண்ணுவீங்க. சரி சார் வராங்க.
உடனே ஸ்டாப் பண்ணிடலாம்.
ஃபேஸ்புக்கில் எடுத்து கொடுத்துருவா?
எனக்கு கொடுத்துருங்க. ஆக்சுவலி உங்களுக்கு ஞாபகம் பிரியாணி வாங்கி கொடுத்தா நம்ம பர்செல்லாம் வீட்டில் வச்சுட்டு வந்தோம். என்ன சட்டையும் காசு இல்லை, என்கிட்டையும் காசு இல்லை. அரேஞ்ச் பண்ணி கொடுத்துறோம். சனிக்கிழமை ரேட்டிங் நம்மளே கொடுத்து வேண்டியதான் பெஸ்ட்டாக.
நடந்தது வீடியோ 4 மணி நேரம் நடந்தது. இதெல்லாம் கால் பண்ணி என்ன பண்ணுறது?